السلام عليكم جميعا، جمعة مباركة إن شاء الله. الحمد لله على سلامة الكل. Good evening, everybody. Dear colleagues, it's a privilege and honor for me as a president of Iraqi Society to welcome you all to the second international conference of Iraqi Society of Metabolic and Bariatric Surgery. Our society has come a long way since 2019 and has surpassed the various challenges that our world has faced over the years and has adapted to the changing technological trends in industry. We have come a long way in making the society a huge success, with more than 80 participants participating in fighting the obesity in all over our country. I would like to express my pleasure at your ever-increasing development and contribution as an important player in bariatric surgery field. I'm sure this event will only add to this profile and help further progress in all areas and the challenges faced in maximizing the efficacy of the sector in terms of improving bariatric surgery and quality of service provided. As someone once said, the show must go on. Not that this is a show, but I appreciate your effort to be together virtually. This is the first conference in the history of our society which is completely conducted on digital platforms due to the COVID-19 pandemic. We are here truly as one committee. We do our best when we do it together. So this is a good first step in the right direction to forge synergy between all of us for one goal we all want to achieve, promote implementation of the best guidelines and solution for bariatric surgeries and its complication. Yes, we all experience an unprecedented situation with the global COVID-19 pandemic. A virus not visible to the naked eye has put the world on pause. It has put into question how and where to go from here. Everybody, every continent grapples with the immediate needs of this public health crisis. We probably only just have seen the tip of the iceberg of the many shifts this pandemic will trigger in terms of socioeconomic fallouts and so much more. We are proud to announce today that the chief of this conference is Dr. Muayad Abass, who will be giving a small speech to walk you through the conference, introduce you to the speakers and delegates that have come from all over the country today to share their knowledge and enhance our mental horizon. I would like to conclude my speech by encouraging the delegates to participate with an increasing number in all the activities and discussions through the digital platforms for the next 3 hours. I wish everyone a successful, safe, and fruitful conference. Thank you.
Thank you, Dr. Ramiz. It is a great honor for me to welcome all of you to the annual conference of Iraqi Society for Metabolic and Bariatric Surgery online webinar 2021. It is an exciting time for the bariatric surgeon with our society as we continue to grow and adapt. It was a very experience to work with the outstanding bariatric surgeons in Iraq, and the results are an attractive and knowledgeable scientific program that focuses on the field of obesity and bariatric surgery. We will continue to meet and bring inspired people together in the conference like this, hoping on the next year to meet you at a real conference in our country, hoping the COVID-19 crisis finished, to ensure our society remains at the cutting edge. On this event, I would like to thank all my colleagues and be able to present their expertise to all surgeons, anesthetists, and health workers. It is a privilege for us to be able to hear from the experts, and I'd like to thank each of you for attending our conference and bringing your expertise to our gathering. You, as society leaders, have the vision, the knowledge, and the experience to help us pave our way into the future. You are truly our greatest asset today and tomorrow, and we could not accomplish what we do without your support. Throughout this conference, I ask you to stay engaged, keep us proactive, and help us shape the future of the bariatric surgery. My special personal respect and thanks goes to Dr. Mohammed Al Hadad and Dr. Hayssam Alfawal for their valuable participation in this webinar and for their great support for our society since its establishment. Special thanks and respect to the IFSO committee for its agreement to endorse our conference. Thanks to sponsor companies and to the IT team and company, Dr. Mohammed and Dr. Abdullah that take over for this webinar. At the last, not the least, my great respect and thanks to my brother, Dr. Ramiz, president of our society, for his trust in me to be chairman for this conference. Thank you very much. I will ask Dr. Nazar Al-Mahfouz as a moderator of this conference to start our scientific sessions.
Thank you, Dr. Mohammed.
Professor Nazar.
Thank you very much. I hope that you hear me. In the name of the Iraqi Society of Metabolic and Bariatric Surgery, we welcome all speakers, participants, and we are so thankful for the IFSO efforts to endorse our second webinar conference and to the British Academy of the Continuing Medical Education for their edition. ROUX stood the test of time as one of the favorable surgery to elicit profound metabolic and bariatric outcome as a primary and secondary revisional surgery. Now we invite Dr. Mohammed Hadad to speak about his review and experience in ROUX. Dr. Mohammed Al Hadad, he is a consultant bariatric surgeon at Health Point Hospital, Abu Dhabi, member of IFSO MINAC, and he has vast contribution in bariatric operations and scientific activities locally and internationally. Welcome to Dr. Mohammed.
Thank you very much, Dr. Nazar. مساء الخير على الجميع. إن شاء الله يكون الجميع بخير. السلام عليكم. شكرا دكتور رامز، دكتور نزار، دكتور مؤيد على الدعوة. يشرفني أن أكون وياكم. بس أحب أقول لكم أنه كل الناس يسألوني مؤتمر العراق شو وقت راح يصير؟ لأن الكل يريد يروح يجي لبغداد. والكل يريد يزور بغداد. بعد المؤتمر والنجاح الأول اللي صار وحفاوتكم وكرمكم، إن شاء الله السنة الجاية الكل يكون بخير ونلتقي بإذن الله تعالى. So my talk, I will talk about the role of ROUX gastric bypass in management of obesity, and I have nothing to disclose. I have one very important disclosure that each surgical procedure to me has its own indications, pros and cons. I'm not against any surgical procedure. I'm not pro of any surgical procedure. I leave the choice for the patient if there is no contraindication for any procedure. However, to be honest, this is my case mix disclosure. I do ROUX gastric bypass around primary as 21% and as a revision around 12%, and the rest are sleeve gastrectomy. This is what I trained for, and this is what I do. So the outline of my talk, I will touch on the obesity definition and causes. I promise I won't go deep in that, it's just a couple of slides. Then I will talk about how do we choose which procedure for which patient. Then we dig a little bit in the role of ROUX gastric bypass. Then I will tell you a little bit about my humble experience, how do we do it in our center, and hopefully you can reach to a conclusion. We all know what's happening with bariatric surgery around the world. We all know that the number of bariatric procedures are increasing. And we know the most common bariatric procedure at the time being is sleeve gastrectomy wherever we go. Roux-en-Y gastric bypass is a little bit declining, and one anastomosis gastric bypass is a little bit going up. To touch on the obesity definition, I always remind myself before I remind others that obesity is a chronic disease. And we as surgeons sometimes forget that. We try to be heroic and we try to think that it is a curable disease. It is not curable disease. It's a chronic disease by definition. And as you see here, from the World Obesity Federation to the American Medical Association to the FDA to the Canadian to the European, there is one word common in all these. It's a disease, and it's a chronic disease. And when we say chronic disease, it's like any other disease. So we have to think about it this way. However, we have to think what's the best approach and how can we help our patients. But we cannot help 100% of the patients. We have to remember that, and I remind myself about this before I remind others. We look at the causes. We know as we go in time, we know more about the causes, we know more about the pathogenesis, but we get more confused. It's an interaction with all these facts. But if you look in the back, there are thousands of factors that affect the obesity and why it happened. So the myth that obesity is just a food and exercise, I don't think it has a place in the 2021. How many diseases or comorbidities are connected to obesity at the time being? So far, we know there are more than 229 diseases or comorbidities related to obesity that affect every organ system and every medical specialty. So how do we choose which procedure for which patient? If we look at the armamentarium of management of obesity, it starts, as you see from the left side or right side of the screen, with the green, diet and exercise, which is the least invasive and least side effect, but it's least effective also. And as we go up, we talk about medications, and the number of medications is increasing gradually. And then we talk about intraluminal devices like balloon and other devices. Now we're talking about minimal invasive endoscopic procedures like ESG, laparoscopic adjustable gastric band, which is a dying procedure. Then we go to the resectional bariatric procedures. And in the middle, we found sleeve gastrectomy, then a little bit Roux-en-Y gastric bypass higher with more complication, one anastomosis gastric bypass, which is more effective than BPD and DS. So it depends where we want to start, but it depends on the case also. We cannot start with diet and exercise with a BMI of 50. So it depends on the patient and it depends. So how do we choose? So the factor affecting the choice, type 2 diabetes is one of the most important factors. And I think there is enough evidence that gastric bypass in general, whether it's a Roux-en-Y, it's a one anastomosis, it's a DS, all these gastric bypass procedures are more effective than sleeve gastrectomy. If we talk about excess body weight loss, also there is enough evidence in the literature up to the time being that gastric bypass in general, whether it's Roux-en-Y or one anastomosis, is more effective than sleeve gastrectomy. However, if we talk about gastroesophageal reflux disease, I don't think there is a doubt that gastroesophageal reflux disease, especially moderate and severe, is one of the contraindications for any other procedure except the Roux-en-Y gastric bypass, because this is the treatment for obesity and gastroesophageal reflux disease. If we talk about safety and the immediate complication, probably sleeve gastrectomy in the immediate period is more safe than gastric bypass, and also on the long term, except if there is Barrett's or development of reflux later on. If we go about age, all the literature support that we go less invasive below the age of 15 or 16 and above the age of 65. So we go with less invasive procedure. Compliance of the patient is a double-edged sword. So if we have a non-compliant patient, we tend to, if we give him a less invasive procedure like a sleeve gastrectomy, the results won't be good. But if we give him a gastric bypass also, the results also will be not good in terms of malnutrition. The compliance is not good. So it's a double depends on patient. each culture is very part, depending where we are doing the surgery. In the east, or the late Dr. Scopinaro saying that if a patient comes from northern Italy, he will treat him differently from the southern Italy because in the they give them a bigger pouch. If he go to the north, they give them a smaller pouch because in the north they can buy lots of meat and protein so they don't develop malnutrition. So we have to adjust according to that. Patient choice and expectation is a very important factor in choosing the operation. And post-op vitamins, of course, we know that all gastric bypass, they need supplementation for the rest of their life. However, I think one of the most important factor is the surgeon. And we all tend, unfortunately, to adopt one of the procedure and consider it like a son or a daughter, and then try to, this is the best operation. This is what we tell the patient. The one that we master is the one that we tell the patient, this is the best operation. Also, what we know about metabolic and bariatric surgery, we know that there are 3 types of patients. There are patients who respond, we call responders, and they do well with one procedure. There are patients who does not respond, we call them non-responder, and there are patients in the middle. They don't respond or they respond and they come back. After around almost 12 or 13 years in the field of bariatric surgery, I think around 30% of the patient will need another procedure. Probably some of you would not agree with that figure, which is fine. But as I see, after 10 years, patients start to come back, and 30% of the patient, they won't reach what they want. If we look at the history of bariatric surgery, from the 50s till now, this is the first bariatric, or it's not an operation, this is the jaw wiring. This is where it started in the 50s. And then with the BBG, then with the ileal bypass, then with the BBG again, Magenstros, then Scopinaro. What we are left with in 2021, the adjustable gastric band, which I don't offer anymore, but I know there are some centers they offer it. The BBDDS, which stayed at 1% all around the world because of the major side effect. And we're talking about the 3 most common procedures, the sleeve gastrectomy, Roux-en-Y, and one anastomosis gastric bypass. And we will talk about Roux-en-Y gastric bypass. And Dr. Nizar kindly mentioned that this is the operation that stood the test of time. So it's the benchmark for bariatric procedure. And each bariatric procedure, when it comes, they compare it to the Roux-en-Y because it's the standard. Here's the father of the Roux-en-Y gastric bypass and the father of bariatric surgery, who recently passed away, who noticed that there is undesirable effect from gastric resection, and he used it for obesity and then became. So what do we know about Roux-en-Y gastric bypass? This is the best evidence we have. This is a level 1 evidence where they compare sleeve gastrectomy to Roux-en-Y gastric bypass. This is a multi-center, multi-country, 5-year outcome for sleeve between Finland and Switzerland. And what they did, they combined the results all together, more than 560 patients. They divide them into sleeve gastrectomy, 233, and they analyze almost 200 patients, and the Roux-en-Y arm almost the same, 200 patients in this arm. So what did they found? With 87% follow-up rate, that Roux-en-Y gastric bypass was superior to sleeve gastrectomy in weight loss, in dyslipidemia, and hypertension. And there was no difference in type 2 diabetes. However, the study was not powered for diabetes and the quality of life. And sleeve gastrectomy, as we know, the rate of complication was less, but not in the severity. We know that, and this is the best study to show the severity and the complications versus bypass, MBA squib, more than 130,000. It shows that the morbidity and the mortality in the Roux-en-Y gastric bypass is more than sleeve gastrectomy, which we know. It's a more complex operation, and the complication can happen in the long term more. How about one anastomosis gastric bypass? This is a nice study. I don't know why not many people code this study. This was done in Spain. They compared 600 patients, randomized control trial, 200 Roux-en-Y gastric bypass, 201 anastomosis gastric bypass, and 200 sleeve gastrectomy. And the follow-up is around 90%, and it's 5-year. And one anastomosis gastric bypass was superior in excess body weight loss, type 2 diabetes, hypertension, and dyslipidemia. And there was no difference between Roux-en-Y and sleeve gastrectomy at 5 years, except in dyslipidemia. However, everything in life comes with a cost. You want a bigger operation, you have to pay a bigger cost for it. We all know the Omega trial, which is a randomized control trial, compared 2 arms, 117 Roux-en-Y, 117 one anastomosis gastric bypass, pretty much the standard operation that we do for ROUX, 120 centimeter alimentary limb and 50 centimeter biliary limb, compared to 200 biliary limb, 1 anastomosis gastric bypass. And they found at 2 years there is no difference, and which we know because the difference usually with time appear more. However, the side effects were more with the 1 anastomosis gastric bypass, and the nutritional complication are more. So their conclusion is not inferior. However, the incidence of malnutrition is more. And this is one of the reasons now of the people, they don't do any more 200 centimeter biliopancreatic limb and came back. And the incidence of complication were corrected by ROUX gastric bypass. So that comes again to the fact that the ROUX gastric bypass is the standard. But what's important in this study, 63 of these patients who had ROUX gastric bypass and 58 who had 1 anastomosis gastric bypass were scoped in 2 years. And not surprisingly, the incidence of esophagitis is 3 times in the 1 anastomosis, and the incidence of metaplasia and dysplasia and esophagitis also was higher. So we want a bigger operation, a better results, but we have to pay a bigger price. So let's talk a few minutes about the ROUX gastric bypass. So this is how we do it. This is how we put the patients. We don't put split legs. It depends where you train. This is my training, so we do this way, and we strap the patient very well. Pre-operatively, we put the patient on very low calorie diet. It depends on the BMI, 2 weeks if the BMI 40 to 50, 3 weeks if the BMI more than 50. We put the patients on fluid diet, and this is not scientific. This is just we figured out that most of our patients, they go in the night before the surgery and they have the biggest buffet in the country. And they eat, and they come in the morning and their stomach is full. So we decided to put them on fluid diet to avoid this. All patients receive ondansetron 8 milligram with induction, dexamethasone 8 milligram, antibiotics 2 to 3 grams depending on the BMI, and heparin 5,000 units. We put sequential compression devices before the surgery. We don't access any midline. We go away from scar. We start with the left upper quadrant, and then we decided about the camera position. And this is where we want the camera position between the colon, the stomach, the liver, and the falciform as it's shown. So we start, just for the sake of time, I will show you 2 minutes video for the JJ anastomosis and 2 minutes for the gastrojejunal anastomosis. So we start, this is the picture, and the first thing I do is check access to the gastroesophageal junction. And this step probably is more important when the BMI is more than 50. We see whether we can reach to the G junction or not. In very rare occasion, in less than 1%, we cannot reach, and then we have to modify the approach. The second is identification of the ligament of Treitz. And as you see here, we identified it, and then we started counting the biliopancreatic limb. We do 50 centimeter if the BMI 40 to 50. We go higher to 100 if the BMI is more than 50. And in the revision, we measure the small bowel. And then we make 1/3 by 2/3. Then we transect the small bowel. Then we dissect a little bit the mesentery. Then we start measuring the ROUX limb. So the measuring of the biliopancreatic limb is with the clock, and this is anti-clockwise. And we usually do the ROUX limb as 100 centimeter. Then we take a stitch between the ROUX limb and the biliopancreatic limb to fix it and not to lose any orientation. Then we make an enterotomy in both. And as you see, we use white load for the small bowel, and we do the jejunal anastomosis. A very important step here to see in the back, as I did, not to involve the mesentery, because if we involve the mesentery, the patient will have a lower GI bleeding, whether now or later. And the last step is closing the JJ defect. And as you see here, it should be very simple, very superficial stitches with non-absorbable suture. Then we do what's called the anti-obstruction stitch. We continue up all the way. This is to prevent kinking at the anastomosis. And this would conclude the JJ anastomosis. Then we move to the gastrojejunal anastomosis, and we start with the dissection of the angle of His. Then we use this finger dissector, or just like a gold finger. Then we measure 4 centimeters from the GE junction, and we open a window between the neurovascular bundle and the lesser curve until we transect. We use blue stapler, the primary cases, and green if we do revisions. Then we continue doing the pouch. The size of the pouch is around 30 milliliters. And we finish by 2 staplers, vertical. We use the gold finger here just to go behind and dissect the angle, as you see here. And then we finish it. Then we bring the rulem in anti-colic fashion, and we do a 2-layer hand-sewn anastomosis. Now, there are many ways to do it. There is linear stapler, there's circular stapler, or hand-sewn anastomosis. Again, it depends on everybody and his training. My training was hand-sewn, and I like it, and that's why I do it. It takes a little bit more time, but I'm comfortable with it. Then we start with the second posterior layer. These are all 30 vicryl suture on a 26 needle. And then we finish the posterior layer. Then we start with the anterior layer. So here we start with the first anterior layer. And before we finish everything, we pass the tube. The tube is a 34 French evacuator tube. So the size of the anastomosis is around 1.2 centimeters, which is always consistent because we pass the tube for it. The last step we do is closing the Peterson space. And as you see here, here's the rulem, and here's the mesocolon. And we close the Peterson space with 2-0 non-absorbable suture. And we finish the procedure by testing the anastomosis, the gastrojejunal anastomosis. Testing now can be done by many ways. What we do in our center, we just do it by endoscopy. Post-operatively, we give all the patients ondansetron 4 milligram Q8 hours regularly, metoclopramide 10 milligram IV 8 hourly regular. We give them ketorolac, which is a non-steroidal 15 to 30 Q8 hours, paracetamol Q6 hours, morphine if they have more pain. We give them 2 doses of antibiotic after the surgery. Everybody 8 hours after surgery receive enoxaparin 40 milligram twice a day, and we give them PPI 40 IV once a day. We move the patients 2 to 3 hours after surgery, and we give them fluid 2 hours after the surgery. We don't do any radiological investigation, and we give them incentive spirometry. When they go home, we continue with the metoclopramide orally, paracetamol, and PPI for 4 weeks. All patients, the BMI 40 and above, they receive enoxaparin once or twice a day, depending on the BMI. And they stay on clear fluid for 3 days, then full fluid for 4 days. Then they go to puree diet, then soft diet, 1 week, and then by week 4, they start regular diet. So in conclusion, I think one of the most important conclusions that ROUX is the benchmark of metabolic and bariatric surgery since 1967, is the one that stood the test of time, and we should compare all the other procedures against it. We know the metabolic benefit of and excess body weight loss of ROUX gastric bypass is more than sleeve gastrectomy, but gastric bypass in general has more complication than sleeve gastrectomy. I think it's the treatment of choice, and there is enough evidence to support that when there is obesity and reflux, the treatment of choice is ROUX gastric bypass. Thank you very much.
Very thankful, Dr. Mohammed, for this nice, comprehensive, stepwise demonstration of the procedure and its valuability. And we will go to the other speaker. And if any question from the audience, we will accept at the end of the presentations. Now, an increasing number of surgeons worldwide are now performing OAGB, MGB. Lack of published consensus amongst experts may be hindering progress and affecting outcome. About 16 experts surgeon has published the modified Delphi consensus statement on MGB-OAGB in 2018. One of the most important experts, Kamal Mahawar and Jack Hempins, Scott Shiroko, and from the Middle East, Ali Khammas, Mohammed Khalid Mirza, and others. Remarkably, 100% of experts felt that OAGB was an acceptable mainstream surgical option. 96 felt that it could no longer be regarded as a new experimental procedure. Now we go to Dr. Mohammed Hayssam Alfawal. He is the master surgeon in metabolic and bariatric surgery from the Surgical Review Corporation, USA, and the fellow in the hepatobiliary and transplant surgery at the Lille University, France. He is the fellow in the American College of Surgeons and the clinical assistant professor of surgery at the Beirut Arab University, the chair of IPSO-MINAC, executive board member, and the previous president, and a well-known expert metabolic and bariatric surgeon, pioneering the sleeve gastrectomy and the MGB, and under the paravertebral block anesthesia in the world. He will speak about why I prefer MGB and OAGB. So we are welcomed to Dr. Hayssam Alfawal.
Good evening, everyone. Thanks, Nidar. Thanks all for the kind invitation. It is always my pleasure to be with my friends, colleagues, and brothers from Iraq. As Dr. Haddad mentioned, we remember very nicely the first Congress in Basra, in the beautiful city of Basra at Shatt al-Arab. We remember very nicely also the historical Baghdad, and hoping that next year we'll meet you all in person. They asked me to talk about a preferred subject for me, which is the one anastomosis, although, as Mohammed said, there is no ideal operation in bariatric surgery, and the surgeons who are solo in choosing one procedure, I believe they are not a real bariatric surgeon. This is my case mixed disclosure slide, and as you can see, lap sleeve still 50% of my practice, but this is the cumulative disclosure slide. So now 50% of my practice is OAGB, 40% is sleeve, and around 10% between ROUX and revisions. And I will tell you during my presentation why. Now, the question we ask ourselves as bariatric surgeon is, what is the ideal bariatric operation? Is it the easiest one like band, which is disappearing now with time? Is it the one with the perfect excess weight like switch or scopinaro? Is it sleeve, which is the most commonly used worldwide? Is it the ROUX, which is, as mentioned now, the oldest, the most studied? Is it the one anastomosis restrictive with malabsorptive? And I personally believe that it is one of the, all of what I mentioned as the ideal for the indicated patient. So there is no real ideal bariatric operation, but I will explain to you why I believe that one anastomosis probably is a good option for a certain category of patients. First, its safety and efficacy have been proven in a lot of studies, and we can see it clearly. It is relatively simpler and easier in terms of learning curve when compared to ROUX gastric bypass, switch, or scopinaro. The excess weight loss and the metabolic control, of course, it is better when we add malabsorption to the restriction. However, as Dr. Haddad mentioned, there is a price for this, which is the long-term nutritional deficiencies and the reflux, which is present in 1 to 5% of patients. Now, for the technical ease, everybody knows from you, surgeons, you know that the anastomosis done in the one anastomosis gastric bypass is really easier to perform when compared to doing the anastomosis at the level of the GE junction. So this is number one. We don't have tension. We don't have to split the omentum like we do in 30–40% of the cases in ROUX gastric bypass. So there is no tension relatively, I mean, in the one anastomosis. It is easily reproducible when compared to other procedures, and this is why I will show you later in my slides the rapid progression of the procedure. So this is one, I think, of the things we should think when we should adopt a bariatric procedure. It should be really reproducible. Again, the quality of life of our patients, and I'm not just talking about my personal experience, the quality of life of patients having one anastomosis gastric bypass is really much better than our patients who did sleeve. The reason why is that they have a relatively larger gastric tube, so they can eat different kind of foods and a bigger amounts when compared to sleeve or Roux-en-Y gastric bypass. And again, always, as we think that 30% of our patients will need later in life a revisional procedure for their obesity, also we should think about the reversibility of our procedures in case of complications like excess weight loss, like hypoalbuminemia, like bile reflux. So the problem with the Roux-en-Y, I think, is that it is not easily reversible or convertible. However, in one anastomosis, the issue is different. You can revert to complete normal anatomy. You can convert to Roux-en-Y gastric bypass. You can convert to sleeve, and it is relatively not easier. بالمطلق وإنما relatively easier. Now, when we come to the Peterson defect, our problem with the one anastomosis is that a lot of the data published in the literature really is not a solid data, are not prospective randomized trial, and the surgeons who are doing one anastomosis, they just want to show that it is a procedure with a very, very low complication and a very excellent outcome, which is not true. If you look at the data of the internal hernias in one anastomosis, you will find just the case reports, one by Genser, one by Hempens. I believe that the internal hernia probably is more, and probably will catch later more and more, but it is definitely less than Roux-en-Y because we have just one defect, which is the Peterson. We don't have the JJ. I didn't have in my experience any internal hernias. I have just one twist of the anastomosis. I will mention it later. But I believe that Peterson defect is present, but whether to close or not, we don't reach a consensus, still present, even in our last OAGB meeting. Now, when we compare Roux-en-Y to one anastomosis and to sleeve gastrectomy, it is the common sense. Whenever you will add such a malabsorption, you will get better, excess weight loss, you will get better resolution of comorbidities. But again, we should weigh the benefit versus the risk. And this is where we should think in the near future to probably ameliorate our one anastomosis by having a good pouch, by having probably less BP limb to decrease the complication, and then probably most of the surgeons will shift from Roux-en-Y unless doing it in its indication, which I believe it is mainly the obesity with reflux or obesity, not super obese patients. Now, if we want to look at the comparative studies between one anastomosis, Roux-en-Y, and lap sleeve, the article just mentioned by Mohammed on 600 patients, the one, I think, prospective randomized control trial. Unfortunately, it is revised now by the surgical endoscopy because there was some misleading information from this article, and it will be withdrawn from the surgical endoscopy, I think, in the coming few months. But there is a lot of data, again, that showed a superiority of one anastomosis gastric bypass when compared to sleeve and to Roux-en-Y bypass in terms of excess weight loss and resolution of comorbidities. I don't want to repeat myself again. There was one study, which is the Omega trial, that showed non-inferiority when comparing both procedures. But again, I always talk about statisticulation, which means playing with the statistics. Any surgeons, and I'm talking about the one anastomosis surgeons and the Roux-en-Y surgeons. When I prefer the one anastomosis, I do a trial in my center. I choose patients, and thereafter I said it is an excellent procedure. I don't have complications, etc. And same apply, I think, for ROUX and other procedures. So probably we surgeons should be really scientists, researchers, not to choose one procedure that we like or we tend to do and just try to convince all people in the world it is the best one. I believe every procedure has, as Mohammed mentioned, his pros and cons. We should respect what the others believe, and we stick to a clear data. So, I mean, for this also non-inferiority trial, the Omega trial that showed non-inferiority between ROUX gastric bypass and one anastomosis, I have a lot of comments on it. I will not go through it, but still, I don't believe this is, although this is a good structured article, I cannot really build on it my opinion in one anastomosis gastric bypass. For the issue of bile reflux, most of the studies showing bile reflux like in 2 to 5%, we should all know that all bariatric procedures have reflux in a different percentages. Now, if you look at this study from Salvatore Tolon, comparing the one anastomosis gastric bypass to Billerud 2, there was no increase in reflux, and it was a good study. I mean, he did the manometry, the gradient, the endoscopy, and this did not show really a significant bile reflux at 2 years. This is not a long-term study. The good thing I'm doing now, we get a fund from the J&J to do a study on one anastomosis to see the histopathologic findings after 5 years of one anastomosis gastric bypass. Probably I will start work on it now. We need another 2 years to get the data, hoping to answer this issue of reflux. But again, another study here between ROUX gastric bypass, a cohort study, and one anastomosis that did not show any difference in terms of Sydney system score, bile reflux index, or complications of reflux. Although I believe personally that ROUX is better than one anastomosis whenever we have reflux. This is shown by most of the data. Okay, also MGB is better as a revisional procedure after any failed restrictive, and this has been shown in a lot of studies. The good one, I think, is from Scott Shikura, and his conclusion was that ROUX gastric bypass is good for reflux, but it is not good for excess weight loss when compared to ROUX. And this is why, if you look now, after I presented all these slides, you will see why one anastomosis is rapidly growing worldwide. You can see all over the world the drop of the ROUX. The steep is #1, and the mostly growing is the one anastomosis gastric bypass. Again, this is not because ROUX is a bad procedure, but people are realizing that probably it has less indication than what was done before. It is same everywhere. It is going up everywhere, except the US. And actually today we had a journal club with our friend Abdulrahman Noori, and apparently even in the US, they started to think about the one anastomosis gastric bypass, and the position statement of the American Society will change, I think, in the coming year to adopt one anastomosis as an acceptable procedure. We in the Middle East published several articles on this. We have one article on the complications, and this is something I will talk in the next slide about liver failure and malnutrition, but this is for the practice in the Middle East, and most of the surgeons in the Middle East are doing sleeve gastrectomy followed by ROUX and one anastomosis, and in Emirates, most of the surgeries Hadad knows better than me, are lap sleeve, and one anastomosis is almost double ROUX in UAE. Of course, you all know the IFSO position statement 2 years ago. So it is recognized as a bariatric and metabolic procedures, and it's not investigation. And however, they encourage surgeons to do more prospective trial and to look into nutritional deficiencies and bile reflux. IQSMBS did not approve it yet, but I'm telling you, this is what I knew, that it will change this year. So if we come to the nutritional deficiency, of course, the problem with the one anastomosis is that when it started like 15 years ago, they used to do 2 meters and above. And apparently 2 meters is too much, because when we look at the study by Kamal Mahawar, when he compared the 2 meters versus 1.5, the nutritional deficiencies and the need for reversal is 0.5 to 2% and the 2 meters and above BP limb. However, it was 0% in patients with BP limb below 150 centimeters. Nevertheless, however, the excess weight loss is almost equal in both BP limbs. This is my personal experience, and I did around 1,100 MGB-OAGB since 2013. Excess weight loss is, like the literature, almost 75% at 3 years, 65 at 5 years. I have a leak rate of 1%, 10 patients who leak. I have 2 incarcerated hernia. I treated 1 with reduction at the trocar site, and 1 needed bowel resection. And I have 1 twist of the anastomosis. I didn't have any internal hernias. I have 1 death from liver failure. I have 1 death from PE, and I have 1 death from leak with multi-organ failure. So I have 3 deaths in my experience. Okay, to conclude, although one anastomosis is recognized by IFSO as an acceptable bariatric and metabolic procedures, I think more prospective studies are needed to prove its long-term outcome, and the issue of nutritional deficiency and bile reflux. Standardization of the procedure to reach a consensus is really a need, and this should be based on science and evidence-based data and not on personal experience. The Hamburg meeting 2 years ago was really a landmark for a consensus. It was supported by IFSO. And probably it needs a presentation by its own to tell you about this consensus. I believe in MGB-OAGB as an effective, reproducible, and safe procedure, and it is my first choice for patients with BMI above 5 with or without morbidities, or after failed bariatric procedures. And after 15 years of experience in bariatric and metabolic surgery, I think, as Mohammed says, there is no ideal surgery for genetic and complex disorder like morbid obesity. And in this era where we are flooded with new procedures, Saad, MGB, OAGB, etc., really we should adhere to the basics of doing the approaches that have a long-term outcome, and leave the rest to be done under clinical trial till we have enough evidence in the literature.
Thank you, Dr. Hayssam Alfawal, for your informative presentation. And we have some questions. It will be at the end of the discussion. Now we go to the third speaker, Dr. Ramiz. And since his talk will be on continuing on the OAGB MGB, we say some of the statements from the Delphi consensus on OAGB 2018. Approximately 96 and 91 of the experts felt that OAGB didn't increase the risk of gastric and esophageal cancer respectively, and 94% of experts felt that construction of the gastric pouch should start in the horizontal portion of the lesser curvature, and there was a consensus of 82, 84, and 85 of routinely supplement iron and vitamin B12 and vitamin D, respectively. So now we go to Dr. Ramiz. He is a consultant bariatric surgeon at the St. Raphael Hospital, Baghdad. He is the member of the Baghdad Medical School faculty, master surgeon in metabolic and bariatric surgery from the Surgical Review Corporation, USA, president of the Iraqi Society of Metabolic and Bariatric Surgery, and he speaks about the management of post-MGB leak. Welcome to
Assalamu alaikum. Good evening. Today, I would like to present this case. I know leak is a bad news for any bariatric surgeon, but let us present this case to learn something from this case. Yes, patient female, 38 years old, BMI 40, underwent sleeve 6 years ago and achieved an optimum weight loss during the first 4 years. Later on, as usual, the usual story, regain weight. I discussed the options, what I can do for her, and the decision was made to convert to OAGB MGB. Simply, I use 180 cm from the DJ junction and the anastomosis gastric pouch. Let us take a short video what happened during the first operation. As you can see, the sleeved stomach dilated, obviously. And let me tell you something. I used to oversoon the site of the stapler. I'm doing continuous lumbar suture to decrease the incidence of leak. So during revisional surgery, usually I will find a great difficulty in releasing this lumbar suture and to make a version area to safely stable the stomach and resize it again. As you can see here, there is a stitch. This is an old stitch when I did the lumbar suture. I hardly dissect this area and I stable it and resize the stomach and create a pouch suitable for MGP. And then, as I said, 180 cm from the DJ, I did linear staple between the jejunum and the pouch, about 3 cm. And everything went good. This is the final picture of the anastomosis. The patient started oral the same day and discharged the next day. Everything is good. Later on, 5th post-operative day, the bad news, patient phoned me complaining of severe abdominal pain, fever. Examination, the pulse rate is 120, blood pressure 110/55, temperature 38, the abdomen soft, apart from tenderness in the left upper abdomen. Complete workup done, including CT scan, biochemistry, hematological test, diagnosis leak. The decisions then met for exploration by laparoscopy, and inspect the abdomen. I found a good amount of gastric material in the around the spleen, subphrenic. I dissect the site of the leak and identify the site of the leak. Then I did I use a 15 cm of jejunum proximal to the gastrojejunostomy, and I did hand-sewn anastomosis to the site of the leak. Then I continue the procedure as a Roux-en-Y gastric bypass. This is a short video explaining the procedure. As you can see, there is a good amount of gastric content. Dissection to identify the site of the leak, which was in the proximal part of the sleeved stomach. And this is clearly, you can see the site of the leak. This one, because it's clear, it's around 2 cm. It's a big one, not a small one. Definitely, there was a technical problem in the first operation that led to such a big leak. Trimming of excess mucosa done to prepare the area for anastomosis. This is mucosa, excess mucosa. Remove. Then, as I said, 15 cm from the gastroduodenostomy. Preparing this limb for the anastomosis. It's not easy to reach freely to the site of the leak with tension, so I decided to open the mesentery a little bit to get more freedom for the limb so that I can do it without tension. I fixed this limb with the left cross to make the anastomosis without tension. Then preparing the site of the anastomosis in the duodenum. It's about 2 cm. Using single layer of V-lock anastomosis. Running the posterior part of the anastomosis, then anterior one. This enterotomy to complete the ROUX anastomosis. About 40 cm from the gastroduodenostomy. This is the alimentary limb. closure of all the defect done. This is the Peterson defect. Finally, I did a feeding tube through the native stomach. Patient post-operatively very well. On the third day, I did for her fluoroscopic test, gastrographin, and you can see this nice picture how the dye passes through the new anastomosis and the other part of the dye going down through the old anastomosis. No leak at all. Patient is very well. So before we start anything, learn how to finish it. Thank you very much.
Thank you, Dr. Ramiz. This is a very courageous salvage procedure and a very nice video demonstration and skill. Now, and we have also, if anybody has a question, we will go after the completion of the speakers. Now, if it were not for the frightful hemorrhage, which so frequently attends them, operations would be robbed of nearly all their terror, and a few men would shrink from their performance. This is by Samuel Gross, 1805, 1884. Now for the speaker, Dr. Muayad Abass Fadil. He is assistant professor at the surgery department, Baghdad Medical College. He is a consultant laparoscopic and bariatric surgeon in hospital, head of the Iraqi Fellowship for Bariatric Surgery, and the vice president of Iraqi Society of Metabolic and Bariatric Surgery. He will speak about the bleeding complication in bariatric surgery. Yes, please, Dr. Muayad.
So our talk will be about the post-operative bleeding in the bariatric surgery. I have no disclosure. Although it is not so common complication, but as we know, the bleeding is a life-threatening complication of the bariatric surgery, and it is one of the complications of the bariatric surgery with the incidence ranging from 1% to 13%. There is wide variation in the publication about the incidence of bleeding after bariatric surgery. As I said, it is ranging from 1 to 14%. I think this variation is depending on the method of the oversewing or the buttressing the stable line. So to understand the problem of the complication of the bleeding, we have to know the potential causes. And also the bariatric patients have specific risk for the bleeding, and bariatric surgery itself has a particular risk and technical issue for bleeding. And then we have to identify the most efficient pathway of the treatment of the post-operative bleeding and how we prevent this complication. So the potential causes, there may be an inadequate hemostasis, high blood pressure, especially the systolic one, tissue laceration, any visceral injury, any GI ulceration, and also anticoagulant is one of the potential causes of the bleeding. Patient underwent bariatric procedure has specific risk for bleeding. They are anticoagulant on chronic treatment. Most of them, they are having chronic illnesses and they need to be on anticoagulant. There may be a complex medication that may increase the risk of the bleeding. And there is a high risk of DVT for bariatric patients, and we have to give a prophylaxis for the DVT. If those patients with non-previous treatment of the hypertension, this may be a cause for the bleeding. Bariatric patients with post-operative bleeding are more difficult to be treated. Itself, the bariatric procedure have a special risk for the bleeding. As you know, we have very long stable line in the bariatric procedure. I think it is the longest stable line in the surgery. And the dissection of the fat infiltration tissue, this have the difficulty in disturb the anatomy and have attention to the anastomosis, and this will increase the risk of the bleeding. Now, what are the treatment algorithm for post-bariatric bleeding? We have the following scenario. Either we have a surgical emergency and we have a life-threatening complication. The patient is in hemodynamic shock, so this will go for surgery immediately. Sometimes we have a self-limited bleeding, either at the wound or intraperitoneal or GI bleeding. And in this situation, we may need to conservatively treat the patient with monitoring of the patient. So regarding the post-operative bleeding, we have the extraperitoneal bleeding, and this bleeding arises from the small arteries or veins and the gastric branches. And this is mostly in an open technique previously. And here we have a problem that we may face an abscess on the future or incisional hernia. The treatment is ranging from the conservative, if it is a small hematoma, or surgical. How we prevent the extraperitoneal or abdominal wall hematoma or bleeding? This is by careful check and control all the bleeders. This video will show us, before you finish your surgery, you have to check the all board site for any bleeding. You remove the boards under vision, checking for any abdominal wall board site bleeding. And the last board will be the optical board, also checking the for the bleeding. We have an intraperitoneal bleeding, and as in this case, we have a collection of the hematoma and the blood, evacuation of the hematoma. Sometimes after evacuation, you cannot find the source of the bleeding. But in other cases, after the evacuation, like in this case, you can find the source of the bleeding, and in this case, in the stable line. This is also an intraperitoneal hematoma after sleeve gastrectomy with a huge amount of the blood and the clots. Also evacuation of the hematoma. This is an intraperitoneal bleeding after the gastric bypass. The same. Evacuation of the hematoma and searching for the source of the bleeding. This is hemoperitoneum following the peritoneal cavity. You have to evacuate the blood. Searching for the source of the bleeding, and in this case, it was in the jejunostomy. Sometimes we have a massive intraperitoneal bleeding and the patient in severe hemodynamic impairment. And as in this case, we have a major bleeding in the gastroepiploic artery. So you have to search directly for the bleeder in such patient and not waste time in evacuating the hematoma. If the patient is in hemodynamic instability, so regarding the intraperitoneal bleeding, the possible site may be in the stable line, and the stable line may be in the pouch or in the native stomach or in the jejunostomy, and in sleeve, it is in the stable line of the sleeve. Or it may be bleeding from the short gastric vessels or gastroepiploic vessels from the omentum or from the mesentery or from the spleen or the liver, or from the site of the dissection of the previous adhesion, or it might be from the access port and causing intraperitoneal bleeding. Sometimes we cannot detect the origin of the bleeding. So how we diagnose the intraperitoneal bleeding? The patient might present with the hemodynamic signs like tachycardia, weak pulses, hypotension, pallor, dizziness, low urine output. There is abdominal signs like moderate pain, abdominal distension, ecchymosis, and in this patient with intraperitoneal bleeding, there is no signs of gastrointestinal bleeding. Also, the lab might aid us. You don't depend on the drain. If you put a drain on the patient in hemodynamic instability, you search for the drain. It is no. Sometimes in this situation, you have to take the clinical state of the patient and don't let the drain make a mistake for the diagnosis. Sometimes the ultrasound and CT scan may aid us to diagnose the bleeding. So regarding the treatment of the intraperitoneal bleeding, we start always by the conservative one, by fluid replacement, blood transfusion, and discontinuation of the anticoagulant therapy. There is a surgical indication, emergency for the hemodynamic unstable patient. If we have a severe bleeding in the first 6 hours after surgery, or if the patient have hemodynamic changes without active bleeding source, like in compartment syndrome after 5 to 20 days after the surgery. Patient have a bleeding, hematoma, and this might cause a compartment syndrome. If you treat the patient conservatively with intraperitoneal bleeding, you have to consider this point. You might end with if you leave the hematoma inside, you might end with intraperitoneal abscess, and this intraperitoneal abscess may cause leak or may weak the site of the stable line or the anastomosis, and you might end with the leak. Those patients who develop intraperitoneal bleeding, they are for high risk to develop the DVT because of the blood transfusion, as it is proved in this article done by the Nelson. Now, what are the proposed solutions to control the post-operative bleeding? We have the buttress material, hemostatic clip, energy on the stable line, glue application, hemostatic foam, or oversewing. Controlling the bleeding during surgery if the bleeders are active, but sometimes we face this problem. At the end of the procedure, the operative field is dry. May the bleeding occur? Yes, it may occur. This article by DOGOG showing us the method of reinforcement, like oversewing, Bariatric, seam guard. This method of reinforcement, they showed that it doesn't affect the incidence of the leak, but it significantly reducing the incidence of the bleeding. Now, how we prevent intraperitoneal bleeding? And as we said, this is by active surge and control of the bleeders. And before you finish your surgery, you have to raise raise the patient blood pressure to 30% over the preoperative range. And this should be more than the intraperitoneal CO2 pressure. So elevate the blood pressure. You have and deflate the CO2 to increase the pressure in the of the patient, and then you have to monitor the blood pressure after surgery, and you have to keep the blood pressure of the patient below the tested level. And for this preventive measure, we have an article done by Moller and Dinemans and Cobasco. They found that this preventive measure of increasing the blood pressure of the patient before the end of the surgery and keeping the post-operative blood pressure under the tested value, it decreases the incidence of post-operative bleeding. This video showing a sleeve at the end of the surgery when the blood pressure of the patient was 100, the systolic, everything is nice, the field is dry, no bleeding, the stable line is dry. Once they raise the blood pressure to 150, the bleeding occurs. So how we control bleeding? Either by applying a clips, or by oversewing, or by hemostatic foam, or using an energy on the stable line. Regarding the intra-abdominal bleeding, also the diagnosis by the clinical presentation, lab imaging, and the endoscopy is very important in such type of bleeding, and it may be a diagnostic and therapeutic. We can evacuate the hepatic loss and making hemostasis for the bleeder. Also, the treatment starting with the conservative, the fluid replacement, blood transfusion, and discontinuation of the anticoagulant therapy. And the endoscopic hemostasis play a role, hemostatic injection, clips, thermal coagulation. Sometimes if the endoscopic measures failed, we have to do a surgical exploration. There is no harm of the anastomosis by the endoscopy, even in the early post-operative period. So we can, by endoscopy, applying eclipse. This video showing an intraluminal bleeding in a case of gastric bypass causing obstruction of the bowel by the clot in the jejunal anastomosis. So making enterotomy to evacuate the hematoma. Now, what are the possible sites for the, what are the possible sites for the intraluminal bleeding? It is from the stable line, gastrojejunostomy or jejunojejunostomy, or from the GI ulcer, and sometimes we cannot locate the bleeding origin. How we prevent intraluminal bleeding? By activating the endoscopy after the surgery, you can search for any bleeding inside the pouch of the bypass or the gastrojejunostomy, because this in this view of the laparoscopy, everything is clear, but by the endoscopy, you can locate any intraluminal bleeding. You can use buttress material for the stapler in doing a gastrojejunostomy. This may minimize the risk of the intraluminal bleeding. And also you can, using the preventive control by increasing the blood pressure of the patient searching for any bleeder. And if there is any bleeding, you can apply eclipse. This is very important slide. You have to choose a proper stapler for the thickness of the tissue. You have to take a stapler with the width not causing a tissue destruction and not causing a dehiscence. So the proper width of the stapler is important when you are doing a stapling of the gastric wall or gastrojejunostomy. By applying these preventive measures, the bleeding from the stable line, they found that if we have no active control of the bleeding, in this publication, there were 24 patients having a bleeding. If we apply eclipse, we have a 5 patient. If we oversewing the stable line, there was a 0 patient. Lastly, we have a case presentation of post-operative bleeding. We have a 50-year-old female patient with morbid obesity, BMI 50, diabetic, hypertensive, of medical treatment. MGB was done and it was uneventful. 6 hours after surgery, patient developed hematemesis with increasing in her blood pressure reaching up to 180 to over 110. Resuscitation of the patient with the blood and plasma trial to reduce her blood pressure hematemesis persists with clots. So decision was made for a relaparoscopy. Before that, the OGT was done and it was not harmful. The pouch was filled with the clots. So relaparoscopy was done. And this video show the same patient on initial gastrology-genostomy. Here we are, I am using the Peri-Operative stapler. Everything is okay, the dry anastomosis, no bleeding, and the surgery ended uneventful. After 6 hours, we re-explored the patient. We found that the pouch is filled with the hematoma. So we opened the gastrology-genostomy. And we evacuate the hematoma. After evacuation of the hematoma, there was a pulsatile bleeding in the stable line of the gastrology-genostomy. The clipping of the bleeder, ensure hemostasis. And then oversewing of the stable line. And again, closure of the gastrology-genostomy opening. Patient doing well post-operatively. So in conclusion, the post-operative bleeding after bariatric surgery, it is potentially serious complication, life-threatening complication. Most of the intraluminal bleeding occur in bypass surgery, while the intraperitoneal bleeding in sleep gastrectomy. Carefully check and active control of the bleeding source is recommended. The implementation of protocol for prevention of the post-operative bleeding is efficient. And thank you.
Most thankful, Dr. Muayad, for this nice and beautiful presentation. You've come over most of the tips of the prevention and controlling the intra and post-operative hemorrhage. And we are waiting for the audience for any comments or question. Now we go to Dr. Falih Mohsen. We are only at the foothills of the understanding of cancer. This is by David Dent. Dr. Falih Mohsen Al-Gazgouz, he is a consultant general and bariatric surgeon. He is the head of the Bariatric and Metabolic Surgery Center, a scholarship at Al Sadr Teaching Hospital, Basra. He will speak about the missed gastric cancer after sleeve gastrectomy. This is a very interesting court case. Most welcome, Dr. Falih.
Thank you, Dr. Nazar. Thank you, Professor Nazar, my mentor in all my life in laparoscopy surgery. Thank you, Dr. Nazar.
Thank you. Most welcome.
Really, it is a challenging case. I'm facing before 2 years. This case was a female of 52 years age and has a negative past medical history. And she complaining from mild dyspeptic symptom and was operated on in other countries in form of sleeve gastrectomy due to morbidly obese patient. And after 25 days, she came for Basra. She complaining of repeated vomiting. It was non-bilious vomiting. And on examination, the patient was dehydrated due to fluid loss. And there is no sign of acute abdomen and no palpable mass on examination. We send the patient for thorough investigation, including the hematological investigation, and there was anemia and hypokalemia. And then for computed tomography, show an enhancing mass in the pre-pyloric area with multiple lymph nodes around the pylorus. And then a plan for endoscopy for this patient. And the endoscopy, there was a there is an ugly looking mass in pre-pyloric area with difficulty to negotiate the scope to the duodenum. That is why multiple endoscopic biopsy taken that reveal adenocarcinoma of the stomach of moderately differentiated type. Then the decision the decision was taken for laparoscopic total gastrectomy with ROUX esophageogynostomy and D1 to D2 lymph node dissection. After 6 days, the patient became well and discharged to home with further oncological treatment. My message now from this case, even I take less than 15 minutes in this subject, but it is very important. My message is endoscopy better to be done in a preoperative assessment, even in a mild dyspeptic symptom. And all of my colleagues, they agree with me that many of our patients, they have accidental finding during laparoscopy in form of a big hiatal hernia, widening of the hiatus, or any mass like GIST or so on. So an endoscopy is better to be done in a preoperative assessment in even mild dyspeptic symptom. And we must give an attention to ask the patient many times for any dyspeptic symptom before we go for surgery. And then my question for all my colleagues, it is better to do or not to do sleeve gastrectomy and endoscopy rather than bougies. That is why we will pick up any intraluminal bleeding, any missed mass or pathology, or even diagnosis of hiatal hernia at time of surgery. Thank you. I'm sorry because the video is not downloaded well, so I can't apply this video for the webinar.
Thank you, Dr. Falih. Very nice case.
Thank you.
Very rare case. It's a must to do endoscopy before proceeding to bariatric surgery. This is a rule, but many surgeons, they sometimes ignore due to some insistence or the hurry of the patients. And we really are insisting on this step, which is one of the multidisciplinary protocols in the procedures of bariatric. And it's a very nice presentation, very nice case. And we are waiting for the comments of audience. And for the sake of speakers, we should say that about more than 106 participants in the conference, in the webinar, are now online, and we have many questions from the audience. We will go to each speaker at the end of the presentation. Now we go to Mr. Sabah Noori. Life is pain, and the enjoyment of love is by anesthesia. Dr. Sabah Noori, he is assistant professor of anesthesia in Baghdad Medical School, and he is supervisor of anesthesia diploma, head anesthesia department, and at Medical City. You will speak about the practical tips and pre-operative anesthesia management for morbid obese patients. Most welcome, Dr. Sabah.
Okay, thank you very much, Saad Nazar, for this nice presentation, actually. Assalamu alaikum jami'an. First of all, I would like to thank my dear friends, Ustad Muayad, Ustad Ramiz, and other members of the society for giving me this opportunity to share my talks with our distinguished surgeons and respected audience. Actually, I have been involved in managing bariatric patients since 2005, and I have to say our experience, our practice was built up and evolved over years since that time to date. In order not to run out of my time, I would like to concentrate or to address certain practical tips regarding anesthetic management of bariatric patients from our perspective as anesthetist. Briefly, I will divide my topics into the introduction to pre-operative assessment, then intraoperative management, and I will concentrate on the pre-operative complications. Next, please, next. Okay. Of course, bariatric anesthesia or bariatric anesthetist needs specific knowledge. Regarding the preoperative assessment, in addition to the routine assessment of any patient that usually done for any patients, bariatric patient needs extra answers and certain calculation. We know BMI should be done for all patients. If it's more than 40 kilograms per meter squared, it's defined morbidly obese patient. If it's more than 50, it define super obese patient. But BMI alone, it doesn't evaluate anesthesia and surgery risk. What's more important, actually, is the waist to hip ratio. It's calculated by measuring the maximum circumference at the hip divided by the of the waist divided by the maximum circumference of the hip. If the ratio is less than 1, this defines gynecoid obesity with minimal risk profile. While if it's more than 1, it defines android or central obesity with high risk profile regarding cardiorespiratory morbidities and endocrine morbidities. Regarding android obesity, which is the matter of concern to us as anesthetists, it's important to localize where the fat is, whether it's extraperitoneal between the skin and fascia or intraperitoneal or omental fat. Actually, CT and MRI, it's fair enough to diagnose or to localize the fat distribution, but sometimes we can do simple tests by holding the anterior abdominal wall with 2 hands, and we try to approximate the middle and thumb, the middle finger and thumb. If we can approximate, we can. This means that the fat distributed extraperitoneal. If we cannot, it means the fat distributed intraperitoneally. Regarding the induction, before we induce our patient, we should make sure that equipment for positioning, especially beacher position, should be available. Equipment to handle difficult intubation, I strongly recommend the availability of video-assisted laryngoscope. We should adapt rapid sequence induction, especially for super obese patients with android obesity because of high intragastric and intra-abdominal pressure, and definitely is the technique of choice to intubate or to secure the upper airway of patient presented for revision, patient with leaks. Here in these three criteria, or three quality of patients, the risk of aspiration is very high. That's why rapid sequence induction is recommended. It means securing the airway without manual ventilation of the lung. And obese patients, it should be done in semi-seated or B-chair position to make use of anti-gravity effect to prevent regurgitation and aspiration. Of course, we use wide blood pressure cuff over the arm, but if it's not available, standard cuff can be used over the forearm with the same accuracy. Thromboprophylaxis always adapted. It's low molecular weight heparin given either before operation, during induction, intermittent pneumatic stoking, sequential stockings can be used with good results, and elastic stoking as well. Regarding induction of anesthesia, drug dosage in morbidly obese patient actually difficult, but relying on short-acting medications with monitoring of its effect usually solve the problem. Pre-oxygenation is important in morbidly obese patient for 3 to 5 minutes, and we guide our proper pre-oxygenation by measuring the end-tidal oxygen concentration. I don't mean here the oxygen saturation that usually measured by the pulse oximeter. End-tidal oxygen concentration is measured by a gas analyzer attached to an anesthesia machine. It should be more than 90% before induction of anesthesia. Rapid sequence induction, as I did mention, is greatly recommended for morbidly obese, for super obese, for android obesity, and patients with leak. Since 2012, a new concept of opioid-free anesthesia was adapted. It means using intraoperative analgesics, multimodal approach. It means different groups of medications can be used together, all together. Apart from opioid anesthetics, very effective in patients with obstructive sleep apnea. In super obese patient, it gives us a quick recovery of the patient without respiratory depression. Optimization of surgical workspace can be achieved. Actually, this is a big problem in bariatric surgery, as you know, but can be achieved by providing deep muscle relaxation during pneumoperitoneum. B-chair position is very important to optimize surgical workspace. It can be performed by semi-seated position with flex hip and knee. It will add extra 700 ml of CO2 to their workspace, which is good volume. Also, selection of upper intra-abdominal pressure specific for each patient is important. This can be done by initial insufflation of 4 liters of CO2 in the abdomen. Then we stop insufflation and we measure the intra-abdominal pressure at the end of expiration. Actually, this defines the maximum pressure limit, intra-abdominal pressure limit. Make sure when the pressure is more than 15, it doesn't affect the peak inspiratory pressure of the patient. In that case, we have to maintain deep relaxation till the end of pneumoperitoneum. Different ventilation strategies were adopted in bariatric patients, but all are the same with the same result. But PEEP should be applied from the beginning to the end of the operation with minimum 7. We should know that PEEP, positive end expiratory pressure, can help to prevent atelectasis, but it doesn't prevent the problem totally. So we have to rely on what we call lung recruitment maneuvers. We increase the PEEP by 5 centimeter water escalation each minute till we reach a maximum of 20. Then we go back to PEEP 7. That's what we call it cycling maneuver. It can be repeated every 10 to 15 minutes. It's very effective to prevent atelectasis, especially atelectasis that happen during induction. And it proved to be very effective in prevention of post-operative atelectasis, which is a major or big issue in bariatric patients. Maintenance of hypercapnia during anesthesia is important. As we know, normally we keep the CO2 of the patient below 40 millimeter mercury, but in bariatric patients, we try to keep the minimum 40 and even above that level. This is what we call it permissive hypercapnia is important during pneumoperitoneum. Hypercapnia increases the cardiac output and increase blood pressure. Increase the cardiac output, enhance tissue perfusion, identify area of potential ischemia as stable lines, and the rise of blood pressure is important to define bleeding spots. It's a routine job for us as anesthetists to increase the blood pressure during stapling. As you know, in spite of the improvement that happened with the stables, laparoscopic stable during the past year, but still stable doesn't occlude the blood vessels completely. So some blood vessels start to rebleed again when the pressure gets high at the end of operation. All of you have noticed, or you have seen when you operate on a system, when you do stapling at a systolic blood pressure below 90 millimeter mercury, all the stable lines are white. Sometimes it's nice for the surgeon to work in a blood-free workspace. But it doesn't give us an idea about the tissue perfusion. When we increase the systolic blood pressure to 110 millimeter mercury, stable lines start to ooze and get red appearance. When we increase the pressure to 140 and above, bleeding spots that might have missed could be visualized, and the surgeon can do his proper hemostasis. Extubation of bariatric patients should be done in semi-seated position. Patient should be fully awake, wide awake, full reversal of muscle relaxant. This is because some patients, if you don't extubate, if you extubate them while they are still anesthetized, it might cause obstructed breathing, which is difficult to be managed in certain cases. So extubation should be done wide awake for reversal of muscle relaxant and in semi-seated position. Majority of our patients are discharged to the general ward without even oxygen supplementation, but rarely we need to admit patients to the intensive care, especially those presented with leaks because of genuine sepsis and organ dysfunction. Also, we recommend referral or observation or monitoring patients with severe form of obstructive sleep apnea in HDU or an ICU setting, especially for the first or day zero. And of course, rarely we face or we encounter patients with obesity hypoventilation syndrome. They carry a high risk of apnea post-op. So such quality of patient should be monitored in a proper unit, intensive care unit. Regarding the post-operative analgesia, once we adopt multimodal approach of analgesic during operation, usually the quality or the severity of pain not that high in post-operatively. So most of the patients, they are satisfied with paracetamol every 4 to 6 hours, non-steroidal anti-inflammatory drugs like diclofenac or ketorolac. It's given once in the day zero, twice in day 1, day 2, minus a plus opioid analgesic, but opioid should be avoided in patients with obstructive sleep apnea. Thank you very much.
Most grateful, Dr. Sabah, for this nice, comprehensive presentation of the anesthetic management of obese patients. And we are waiting for the audience for any question. Now we go to Dr. Mostafa Osama to unveil the secret of weight reduction and by the effect of lap sleeve gastrectomy on weight reduction. Dr. Mustafa Osama, he is assistant professor at Al Mustansiriya Medical School. He is consultant general and bariatric surgeon at Al Yarmouk Hospital, Baghdad, and he is supervisor of metabolic and bariatric surgery. Most welcome, Dr. Mustafa. After the speech of Dr. Mustafa, we are waiting for the discussion, and then for the next session of the companies sharing our webinar.
Our talk at this night about the effect of the sleeve gastrectomy on serum Visfatin, Ghrelin, Leptin level, and their correlation with the lipid profile and insulin resistant in morbid obese patients. Obesity. Obesity was considering as a chronic progressive relapsing disease process that require intervention. Increased body weight is a problem worldwide, which is a major risk factor for diabetes, cardiovascular, and affecting more than 180 million people around the world. This number of patients predict to increase to 300 million by 2025. Most cases of human obesity probably result. The comorbidity and complication, as all we know, type 2 diabetes, dyslipidemia, cancer risk, mood disorder, heart disease, reproductive disorder, liver disease, hypertension. Bariatric surgery is the most effective treatment for morbid obese patients. It is associated with significant and sustained weight loss. It is more effective than the lifestyle or medical management in achieving the glycemic control, reduction in morbidity, mortality from cardiovascular and even cancer. The safety of bariatric surgery has been improved tenfold during the last decade with the advancement of the laparoscopy. Bariatric, as all we know, divided into 3 groups depending on their mechanism of the weight loss: malabsorptive, restrictive, and mixed malabsorptive and restrictive. We are talking about the laparoscopic sleeve gastrectomy is a restrictive procedure, irreversible. It is firstly described in 1988, the first step before biliopancreatic diversion with a duodenal switch in super obese patient body mass index more than 50. The first report of sleeve gastrectomy as a standalone operation was done in 2003. The resection comprised 70–80% of the stomach, and the remnant gastric has the capacity about 100 ml. As we know, the sleeve gastrectomy is less technically demanded, has limited morbidity, has no foreign material, without marginal ulcer, internal hernia, or nutritional deficiency. The step of operation, as we know, by 5 ports as shown in the figure. Now we are talking to our topics. What is the adipokines? Adipokines are defined those cytokines secreted by adipose tissue. Leptin was the first adipokine to be discovered in 1994. So this will change the name of the bariatric surgery into the metabolic surgery. So what is the leptin? Leptin is derived hormone secreted from the white adipose tissue. It has many biological functions. The leptin signaling pathway on the hypothalamus about different pathways, as we show in this figure. The total or the network, the function of the leptin is the inhibit the food intake by triggering of the signal pathway into the hypothalamus. What is the Visfatin? A Visfatin is a polypeptide of 49 1-amino acid with a molecular mass of 52. Visfatin is majorly expressed and secreted from visceral fat rather than the subcutaneous fat. So its name is come from it. It was found released mostly from the macrophage, not from the adipocyte. In this regard, produce a response to inflammatory signal. The biological function of the Visfatin, the main biological function, it is insulin mimic adipocytokine. This will act on the insulin receptor. It is not competitor, it is a function of the insulin. It play a role, a pivotal in the pathogenesis of the obesity and metabolic syndrome, and major biological function can be summarized by this figure. It is act on the visceral fat, not on the subcutaneous fat, and enhancing the insulin activity. What is the ghrelin? Ghrelin identified an endogenous ligand for growth hormone. It is a 28 amino acid in addition to promote the growth hormone release. Ghrelin has been further involved in the regulation of the appetite, the gut motility, secretion of the gastric acid, blood pressure, insulin secretion. So ghrelin system can be divided extraordinarily sophisticated and multifunctionally regulatory system. You see, it increases the appetite and the food intake. It has a cardiovascular effect. It affects on the endocrine system, stimulation bone formation, modulation of the cell proliferation, and extra function of the ghrelins. What is our aim of study? To evaluate the change of the serum Visfatin, Ghrelin, Leptin, lipid profile, insulin resistant in morbid obese patient, underwent sleeve gastrectomy, and follow them after 6 weeks to study the effect of reducing the stomach size, weight loss on these parameters and after operation. Second, to compare this study parameter after 6 weeks surgery with healthy control and study the correlation coefficient between the study parameter at the baseline at the time of take the sample and after 6 weeks. What is our subject from this study? This is an interventional study. Prospective was conducted in Al Arabi Private Hospital in Baghdad. For the collection sample started in the 1st of July, of November 2018 to the 4th of May 2019. The number of patients enrolled in this study, 80 subjects, which is divided into 3 groups. The first group, it is a 20 morbid obese patient, 8 male, 12 female before bariatric surgery, a range of age between 20 to 51 years, the body mass index range from 36 to 54. Second group, the same first group, those 20 morbid obese patients after 6 weeks of surgery. Third group, it is 40 healthy, lean subjects, 16 male, 24 female in a range of age between 21 to 55 years with BMI ranging from 18.75 to 25. Exclusion criteria from this study, patients who had an acute illness, acute or chronic inflammatory or infective disease, end-stage malignant disease, any menopausal woman, any woman receiving contraceptive treatment, any prostatic disease in male, or patient did not complete the follow-up were excluded from this study. The result. You see the body mass index characteristic of 3 groups included in the study demonstrated in table number 1. There is a statistical significant decrease in the body mass index in compare with the healthy control. In compare with the fasting glucose, fasting insulin, and insulin resistant mean HUMA for the patient with the pre and post surgery with the control, there is significant decrease in the fasting glucose between the patient before surgery and after 6 weeks of the surgery. About the fasting insulin, there is no statistical significance between the patient pre and post surgery. So when we calculate the insulin resistant equation, we thought there is no statistical significance between the patient pre and post surgery. But when we compare with the healthy control, there is statistical significance. If we compare to the lipid profile patient pre and post surgery with the control, there is statistical significant decrease in the triglyceride level and very low density lipoprotein, also statistical significant. And regarding the cholesterol and low density and high density, there is no statistical significance between the pre and post surgery. Regarding the Visfatin level hormones for morbid obese patient before and after surgery with the control, the study demonstrated decrease, but statistically not significant for patients with the pre and post surgery. But when compared to the control, there is significant decrease in both situations. Regarding the leptin level for morbid obese patient before and after surgery with healthy lean control, there is statistical significant difference for patients after 6 weeks of surgery. And also when we compare to the healthy control, there is a decrease statistical significant with the healthy control. Conclusion and discussion. Laparoscopic sleeve gastrectomy, it is an effective surgery that yields significant weight reduction. There is a significant decrease in the fasting glucose after surgery. There is a reduction in the fasting insulin and improvement in the insulin resistant measured by HUMA, insulin resistant after surgery, but statistically not significant. There is a significant reduction in the level of triglyceride and very low density lipoprotein after surgery. If we are talking about these, we see the laparoscopic sleeve is better for the triglyceride and very low density lipoprotein, while for the cholesterol level, it is more decreased with the malabsorptive procedure. There is significant increase in the serum Visfatin leptin in morbid obese patients in compared to healthy control. There is decrease in the serum Ghrelin in morbid obese patients in compared to the healthy lean control that statistically not significant. Okay. There is a decrease statistically not significant at the level of the serum Visfatin in morbid obese patient after surgery, because as we know, there is the Visfatin. It is a visceral adipokine. It is act on the hepatic insulin resistant. Need more time to return to the normal level. So our study was 6 weeks, but if we are comparing, if it is more time in the 3 months, the statistical becomes significant. There's also elevation that statistically not significant in the serum Ghrelin in morbid obese patient after surgery. And the explanation for this, in spite of we are removing the fundus of the stomach, but still there are other Ghrelin cells like in the duodenum still can secrete the Ghrelin levels. But there is also reduction in the serum level of the leptin in morbid obese patient and after surgery. Regarding the correlation, there is a weak positive significance between the pre-HUMA insulin resistant and the serum Visfatin. That means when there is a decrease in the insulin resistant معناتها requirement إلى الفيسفاتين راح يكون أقل حتى يقوي الأكشن مال الإنسولين، وبالتالي راح يقل عندنا الفيسفاتين، يقل الإنسولين resistant، راح يقل عندنا serum Visfatin post surgery. Strong positive correlation between the pre-insulin and serum Visfatin. كلما قل الليفل مال الإنسولين كلما قل الليفل مال الفيسفاتين، والعكس كلما زاد الإنسولين ليفل زاد الإنسولين Visfatin، وهذه أثبتت الدراسة. A strong positive significant correlation between the body mass index and the post serum leptin. This can be explained in spite of the reduction in the body mass index. Still, there is a decrease in the food intake by emotional and psychiatric stimuli to the brain. Recommendation. The recommendation, according to the finding of our present study, further study are needed with longer course of follow-up visit post-operatively in order to fully demonstrate the change in the circulating level of this hormone, and increase the time point of sampling. يعني احنا بهاي الدراسة كان 6 weeks لكن ممكن نزيدها إلى 3 months أو 6 months و increase the sample size of this study. And thank you.
Thank you, Dr. Sabah, Noori. There is a great effort spent on this study. We are proud of your study and about the hormonal changes post-bariatric surgery. Appears that Dr. Sabah Noori is the final speaker here, and then we go to the discussion session, and I invite my colleague, Dr. Ramiz, and we have the questions. We start with Dr. Hadad, if he is online.
Thank you, Saad.
Okay, Dr. Ramiz, ready?
Yes, ready. Thank you. Thank you for all speakers.
Yes.
The material exposed today, I think it's clearly very rich. And I know every one of us have a lot of questions to be asked for all the speakers. But unfortunately, the time is is limited for us as standard to discuss. So that we are going to concentrate on certain questions. One of the very important, I think, questions to Dr. Hayssam Alfawal regarding mini gastric bypass. Do you think that the whole length of the small bowel make a difference regarding the biliary pancreatic limb, or it doesn't matter?
Well, there is no sufficient data to support the RAM is still present doing the total small bowel length measurement. The only time I do the total bowel length measurement is whenever I'm doing revisions. So I should go above 2 or 2.5 meters. Then I do the total small bowel measurement and I take 1/3, 2/3. I'm not a fan of the one anastomosis done by Carbajo, so I did the traditional MGB-OAGB done by Rutledge. So what I do now is 1.5 meters for the primary and 2 meters for the revisions. We should remember always, Ramiz, that having a reproducible procedure is important to have an easy procedure and less complications. Running the whole small bowel really for the youngster and for the young surgeon is not an easy thing to do. And the incidence of doing, let's say, small bowel injury or changing the trocars or changing position to do the total small bowel length measurement is not easy. So the consensus meeting now is to do 1.5 to 2 meters. If you are going for revisions, then yes, do total bowel length measurement.
Okay, thank you very much. Okay, we have another question for Mohammed Hadad. I think technically, as you said, and you prefer hands-on gastrojejunostomy. Do you think that it's better result minimizing the risk of leak regarding if you do it in circular stapler or linear stapler, or it's a matter of personal preference?
Thank you for the question. There is no evidence to support one way of doing the gastrojejunostomy over the others in terms of leak, but definitely it has a benefit of controlling the size of the anastomosis and less incidence of bleeding from gastrojejunostomy because it's hands-on. But there is no literature to support that there is a leak or there is less leak or more leak with one or other procedures.
Okay, thank you very much.
One question for Dr. Al Hadad from the audience. Why use dexamethasone?
Dexamethasone used to decrease the edema of the anastomosis. And it works very well.
Is it routine?
And even, sorry?
Is it routinely used?
Yes. Yes, pre-operatively used routinely, and patients when they have vomiting, also post-op, we give them 1 or 2 doses. It helps a lot.
Sometimes
with the sleep and the bypass.
Thank you very much. Dr. Ramiz, you have questions?
Yes.
Yes. First question is choosing the size of stapler affecting the leak, especially in your case?
You mean the size of the stapler of what?
Of the revision of the sleeve. You revise the sleeve and then you do the MGB. So definitely there is thickening and fibrosis at the previous stapling.
What happened to my case, it's regarded to the thickness and the selection of the color of the cartilage for stapling. I think there is, as I said, when I did sleeve gastrectomy previously, I used to do continuous lumbar suturing to cover the site of the staple so that to minimize the risk of leak. And that what happened, I'm making a stapling over this 4 layers of gastric wall. And that's what happened. The patient end with leak, as you see in the video clip. So the problem is not this size of cartilage, rather than it's a technical problem.
Yes, yes.
Dr. Mahfouz, if you allow me to comment on the case of Dr. Ramiz,
Yes, please.
An excellent roux-en-y gastric bypass salvage one. But I think in a case of leaks of one anastomosis gastric bypass, really the approach is to try conservative as much as we can. What I mean by a conservative is if we can do less, probably it is better. It is not easy in septic conditions to go and convert patients to a roux-en-y gastric bypass. So doing a sort of drainage, and I personally, really, we cannot talk about my experience. It is around 10 cases of leak, but there was a published literature on around 60 leaks, and 70% were treated conservatively, and it works. So at the end of the day, it is the decision of the surgeon in the operating room, but I want the message to be clear to all surgeons who hear this presentation that if we can do it conservatively, I mean in means of putting drains inside the leak or refashioning the anastomosis, not to go for a major procedure. This is my opinion for the leaks and one anastomosis gastric bypass.
I do agree with you, but I think it's applicable for a small leak, a minor leak, not for a 2 cm leak. I don't think so. The problem will solve with conservative way. This is my opinion.
As I said, it is the decision of the surgeon. I respect your decision, Ramiz. It is an intra-op decision. You will take it, yes, and you will hold responsibility. And I have two perforations of the gastrogenostomy where I have it really 2 and 3 centimeters, and I just put a Foley catheter inside and it works perfectly well. Just remember that the pressure into the tube and the one anastomosis is not as high. So it is not like the leak from sleeve gastrectomy where really we need to go radical. Again, I congratulate you. It is an excellent technique, but again, this is my opinion.
Thank you very much. I respect your opinion. One question for Dr. Muayad for the audience. You have a question, Dr. Muayad?
Yes. Dr. Mohammed Hadad?
Naam.
Do you hear me? Thank you for your nice, brilliant presentation, Dr. Mohammed. I have just 2 questions for you. Regarding the biliopancreatic limb and the alimentary limb length, you said you depend on the BMI. This is for this is for the primary roux-en-y. What about the revisional roux-en-y for failed previous surgery like a sleeve? Still, you depend the same adjust?
We measure the whole small bowel, and we do 1/3 by 2/3. 1/3 is biliopancreatic limb, and 2/3 will be common channel.
Okay. What about the your opinion about the new trend of increasing the length of the biliopancreatic limb and reducing the length of the alimentary limb?
We don't really
biliopancreatic limb about 150 or 200 and reducing the alimentary limb.
As a standard, I don't do it. As a standard primary procedure, I don't do it. I worry about malnutrition. I worry about anemia. Now, the majority of the patients we have here in the UAE, they have they are female. 70% are female. We operate on, just like everywhere. And those patients, usually they come with anemia. Most of them, they come with anemia. So we worry when we make the biliopancreatic limb longer, then they will develop more severe anemia post-op. So that's why when the BMI is 40, 50, we don't go more than 50, 60 centimeters. When it's higher, we go for 1 meter. When it's a revision, we do measure the small bowel length.
Second question, Dr. Mohammed. For those patients decide to do roux-en-y and they have a hiatus hernia, do you usually repair the hiatus hernia in all cases?
Very good question.
Or you
Very
just do a roux-en-y as it is an anti-reflex procedure?
It depends on the size of the hernia.
Okay.
So if we have a hernia more than 2-3 centimeters, 2-3 centimeters, we can just depend on the roux-en-y because it will pull it down. It's a low pressure system. But if it's more than 3 centimeters or there is a dimple anteriorly, we do repair the hernia.
Okay. Thank you very much, Dr. Ahmed.
Sorry.
Question for Dr. Muayad from the audience. The question is for bleeding intraluminally. Is it better to open the jejunum or the stomach?
Really, it depends on the procedure, whether it is a gastric bypass or sleeve. I think the bypass, so it is ideal to open, if it is in the pouch, so it is ideal to open the gastrojejunectomy opening, not going to the jejunum or ascending up to the pouch, as it was evident in my video. Thank you.
Dr. Ramiz, any comments?
Any question from the panelists? Anyone want to share?
I have a question, Professor Nizar.
Yes.
Yeah, welcome, Dr. Falih.
For Dr. Mohammed Al Hadad, thank you for your nice presentation. My question is, there is a difference if you operate on a patient for metabolic cause or for weight reduction regarding the pilopancreatic length?
Not really. Not really. You mean if the patient is diabetic, we make the pilopancreatic limb longer, or no, we depend on the BMI.
Only
on the BMI, yes.
So you not regarding the metabolic disorders?
No,
okay.
It's a very good question. Probably in the future we will know the answer, but I don't do it personally.
I think I choose more longer pilopancreatic limb in a patient with metabolic disorders rather than a weight reduction.
I agree with you, yeah.
You agree with me, Dr. Nizar?
Yes, definitely.
Definitely. Thank you, Dr. Mohammed Al Hadad.
Tislam, Habibi. Tislam, Muhammad. I have a question for you.
Okay.
So you do endoscopy on all the patients, right?
440 patients in a research.
No, I mean every patient that
no.
Bariatric
no, not routinely.
Not routinely.
Honestly, in most of our patients, I do endoscopy, but I choose 404 patients just for a research, and I found what are the limitations of procedure regarding endoscopy.
Because we have a problem of doing endoscopy on all the patients. We would like to do endoscopy on all the patients.
Really, I trust to do endoscopy.
Unfortunately, 98% of our patients are insurance. The insurance will not approve the endoscopy pre-op if there is no reason.
Sure.
And sometimes we tell them there is reflux, there is dyspepsia. They don't agree on this just like this. They want more detail. They want how long it's been there, what are the PPI they used, what's the treatment, what did you do for it? And sometimes they ask for H. pylori test, breathing test, urea breath test just before approval. So we struggle with these patients for approval. That's a problem. Yes, it is ideal to have endoscopy on all the patients.
Endoscopy.
But by the way, it's brilliant that you picked it.
Can I have a question?
Can I have a question? Okay.
Dr. Mohammed Hassan.
Yes.
Please.
Assalamu alaikum. I have a question to Dr. Mohammed Haddad. Dr. Mohammed.
أهلا وسهلا. تفضل.
How are you? Dr. Mohammed, regarding the Roux-en-Y after a bad sleep, let us talk about narrowing after a bad sleep.
Yes.
Tell me how you deal with the remnant of the gastric pouch. Did you resect all the gastric pouch or part of it, and why?
It depends. If the patient had a dilated fundus, if the size of the pouch after we pass the tube, those patients we put them in a lifestyle modification program before. We do we do endoscopy. I do the endoscopy myself, not the gastroenterologist. So I see what's the size of the pouch.
Yes.
And then we do an upper GI study with barium to check the size of the pouch. So, and during surgery, if we pass the 34 evacuator tube or the French tube, if the size of the pouch is more, we trim the pouch.
Yes. And you hand swing?
Or the anastomosis?
I mean the pouch after you resect it? By a step? Depends. Okay.
It depends. If it's bleeding, yes. Most of the cases, yes.
Yes.
Most of the cases, yes. We oversaw it. We oversaw it with Lambert suture.
Yes.
Through and through.
And what about the antrum, remnant of the stomach?
No.
You do. I mean, my question: you do sometimes gastrectomy for the remnant to prevent stasis after the surgery?
No.
No, not any cases.
No, I've never done it.
Yes.
But one trick I do, I put some clips on the remnant stomach.
Yes. Why? Just to check for the leak if happened.
In the future, and if I do CT scans, these clips will tell me which part is which.
Which, okay.
One or two clips, just in case.
Yes. Another question, when you talk about the redo surgery after sleeve gastrectomy and how we decide the length of the, that Dr. Ramiz already asked you, about the length of the BP and the limbs. And you mentioned that you choose it 1/2/3. I mean 1/3 by 2/3.
1/3, yes.
Now you will go outside the standardization between when we not depend on the body mass index. I mean, when we have a 45, we choose a standardization. We have a standardization before above 45 and below 45. So you don't depend in these cases.
Yes, because these patients are either non-responders or partial responders.
Yes.
They are more difficult patients, so we have to use a bigger operation.
Yes, and the third question, if you allowed me, I see you do a hand swing. That's also I do it when I decide to do the anastomosis between the gastrojejunostomy. But you use Vicryl, and I usually use PDS for the inner layer and the Prolin for the outer layer. What's your opinion?
I don't prefer it's okay, but I don't prefer to use non-absorbable suture because the incidence of stomal ulcer is higher.
Because of the stitches.
Because of the stitches. So if you use any non-absorbable stitch, the incidence of stomal ulcer will be high.
Yeah.
And usually the Vicryl is like few weeks.
Sorry about interruption. Sorry about interrupting you because we don't have enough time. I think there is a question for Dr. Haytham Alfawal. You have a question?
Yes, I have a final question, if you are allowed to also. Mohammed, you mentioned during your presentation that 30% of the bariatric patients will ultimately need during their lifetime another procedure. And from the data also, we see like 50 to 60% will have weight regain during their lifetime. So what is your consent to the Roux-en-Y gastric bypass patients in case they regain weight? And what is your options in terms of revisions?
Thank you. A very good question. The answer is simply these patients need to be fully studied, whether they are hyperphagic, they are polyphagic, whether there is an anatomical problem or there is no anatomical problem. So if there is no anatomical problem, the only option is distalization. If there is an anatomical problem, can be dealt by endoscopically, or I don't do it, but we refer here to our colleague Matt Crow, and we have few cases where resizing the pouch or resizing the anastomosis, which works. If there is an anatomical problem with dilated pouch, which can be fixed laparoscopically or re-anastomosis. So the options are a little bit limited, and this is one of the drawbacks on the Roux-en-Y gastric bypass. But when you compare it to other procedures, the people who regain the weight are less than other procedures, but it is one of the drawbacks. But these patients need a complex workup to make sure they will not go back to the same habits, but the options are limited.
Thank you.
Dr. Ramiz, I think we go to the conclusion of the discussion because of the time, and we have the sponsors session. Yes, the second is applied company, Dr. Ahmed Sankari. He will speak about a new generation medical device company. I would like to invite him if he has to speak, please.
Assalamu alaikum, everyone. Can you hear me? Perfect.
Yes. Okay, proceed on. Welcome.
First of all, please allow me to thank the Iraqi Society of Metabolic and Bariatric Surgery. I was very happy to attend the Congress today and the webinar. And as everyone said, I hope next year we will be having it together in Iraq, inshallah. So I'm going to start my presentation right now. For all of you who do not know who Applied Medical is, I'm going to give a brief introduction about the company, about Applied Medical, and then I'm going to talk a little bit about the products that we have, and hopefully I will not cross the 15 minutes mark that was allocated to me. So Applied Medical, represented by ISM in Iraq, has been there for the last 30 years. We're a privately held company established in 1987. We manufacture products for a wide surgical specialties, and of course, bariatric is one of our targets, since you deal a lot with laparoscopy and with the abdominal surgery. So please let me tell you about the first product that was ever invented by Applied Medical. It wasn't a product itself, but it was a belief. A lot of companies are built around a certain product, technology, or innovation. For Applied, our belief was whatever we are going to bring to the market, to the surgeons, and to the patients, we have a commitment to bring the best technology, the best quality, and make it affordable. I've heard some of the surgeons today talking about options in surgery and the cost per surgery. And we would like to make the surgery affordable to every single patient in Iraq, in the Middle East, and in the whole world. So that's why most of the products that you're going to see in our portfolio have a lower price and affordable price, and with high quality and technology. So Applied Medical every single year spends around 20% on its research and development. This is why hopefully when you start working with us, you're going to see a new product in every single few quarters that you work with us, or a new generation of a product that you already will be working with us on. Our company is completely vertically integrated. What does that mean? Every product that you're going to be using from our side is designed, developed, manufactured, sterilized, packaged. Every single thing is done within the company itself. We don't rely on any form of outsourcing. The only two products that we bring to our company is the plastic pellets and the sheets of stainless steel. And the whole catalog that will be with you is a production at Applied Medical. Actually, all of our products are FDA approved and CE approved, and the FDA usually use us to train their new team members, because if someone joins the FDA, when they come to Applied Medical, they can see the whole process from literally raw material up to the finalized products. We are not only an assembly place, we do everything ourselves, and we have a lot of pride on it. So what is our market impact? You all are in the middle of this, so you know the stapling, the energy, the access, the hand instruments, the retrieval bags, etc., etc. All of these devices combined in the US are around $3 billion between all companies combined. Applied Medical, the last few years, have emerged to be the #1 supplier of trocars in the US. And not only that, we forced the other players in the market to bring down their prices, because now there is a better alternative that's coming at an affordable price. Because of that, we were able to shrink the trocar market, although the volume were increasing, but we were able to shrink the market in 10 years from $450 million down to $300 million, because what I mentioned, because we grew to #1 and we forced other companies to go down. In the same timeline, the energy market went from 600 million to 1.4 billion. And today it is estimated to be around 1.6 billion. And the reason for that is we weren't available in the energy market up to 2016. But you're going to see me in my slides talking about it in a bit, because the last few years we've been in this market. So sorry for the 5 minutes introduction, but I just wanted to let you have a feel about the company that you're going to be working with beyond the products themselves. But as I told you, we currently hold the #1 trocars, #1 market share in trocars in the US, Europe, and in a lot of the Middle East countries. We have a wide range of products, from the optical non-bladed trocars to the bladed, to the key balloon blunt tip, to the dissecting balloon. We cater to your needs as surgeons. So the first trocar that I want to be talking about is the key fios, which is, if you look at the tip here, is our non-bladed trocar, and it's also optical. The amazing part about this, if you see from the picture, because it's completely non-bladed, it doesn't have neither a stainless steel nor a plastic blade. It's formed of a sequential helix. This is why once you start removing the trocar out of the abdomen, you're going to see the tissue reapproximation. And this will leave you with smaller incisions and less facial defect at the end of the surgery, which causing less bleeding and less chances of hernia. The other cool part that this technology has is, if you notice here, there is a small opening at the tip of the obturator, which will allow you to insufflate the abdomen as you're going in. So the second this tip crosses the peritoneum and enters the abdominal cavity, you're going, first of all, to see it on your screen because it's an optical trocar. Second of all, you're going to notice it from your pressure machine because the pressure will drop from the high pressure that's in the abdominal wall down to the pressure in the abdominal wall cavity. And the Foyas is the only FDA-approved product that can insufflate or can enter a non-insufflated abdomen. So as I told you, this product is also optical. So as you're going in, you can see the layers, the subcutaneous fat, the rectus sheath, the peritoneum, and when you enter the abdominal cavity. So for who have been using the Veris needle or a direct entry, this is a solution for both of you. And of course, as I told you, our line is very big. So we'll get the chance to speak about it, hopefully one-on-one when we start visiting you. So I talked about the tip of the trocar. What about the cannula? We have many options. I'm sure many of you are familiar with the Hassan technique. Some of it called Hassan. I'm not very sure in Iraq what it's called. But as you see, we do have the key balloon blunt tip trocar, which we replace the plastic cone with a gel cone, and there is a balloon as a double sealer, so there will not be any leak of pneumo for your camera port if you're using the open technique. The cool part that we have at Applied is even for your secondary port, not only for your cut down technique, there is the key advanced fixation, which as you see, the tip is, it can be shielded bladed or it can be optical, but this is also used for secondary port. And the reason why it's used is to give you maximum working space and increase visibility. I'm sure a lot of you, especially when you're working in lower pelvic areas or when you have a lot of instruments inside, sometimes you ask your residents or your assistants to pull the trocars a little bit so you have more working space, and sometimes the trocar is pulled a little bit more and it enters the abdominal cavity. So with the advanced fixation, once you enter with the trocar, all what you have to do is insufflate it with 5 cc and it lasts for you the whole surgery. You don't have to worry about the trocars at all. So jumping from the trocars, I'm going to go to our energy system that I just mentioned a few minutes ago that was launched 4 or 5 years ago. And I'm glad to share with you that today Applied Medical is on the 2nd generation of the Voyant devices. What is Voyant and what makes it more special than the other devices that are in the market is that it's really the first electrosurgery device that's intelligent. While other companies usually measures only 1 or 2 variables, Applied Medical can detect the nature of the tissue, which will deliver the specific amount of energy, leading to faster cycle times, less smoke plume, and less tissue adherence. Now, the question is, how do we do that? If you see from this slide that I have right now, I don't show at all the device. All what I'm showing you is the plug that we use. And the plug that we call is called the device key. So in our device key, where you see it in any other company, it's a normal plug. So for us, we have a chip inside the device key. So actually every device key has its own smartness. The smartness is not in our generators, it is in our device key itself. What does that allow us to do? It allowed us to do the last 5 years to keep on collecting these device keys and studying them more and more and more, and do more clinical study, get the FDA and CE approval to release our newer and newer scripts. And today we are using a script that's very fast. As I told you, have minimal smoke plume and almost have 0 tissue adherence. When it comes to the instruments, we do have the regular blunt tip, we have the Maryland Fusion, and we do have devices for the open surgery. The generator is very simple. It's plug and play. Once, as I said, once you put the device key, it's easily recognized by the generator. It knows exactly what energy it has to deliver. But please don't hold me to what I'm saying. I would like each and every one of you to try it themselves and just see the difference between what you have been using and the difference with what we have introduced to the market. Another family that I would like to speak about, so I talked about the trokers, the axis, I talked about the energy. Another family that's very unique for applied, and some of you might have recognized this family, is the gel point family. So the gel point family can be used for single port, it can be used for transanal access or transvaginal access. Of course, as bariatric surgeon, I'm going to focus a little bit more only on the single port. And I know that this is debatable in the community, in the surgical community, whether single port is better or not better. So I'm not here to make the clinical decision on your behalf, of course. You do what's best for you and your patients. But for you who are interested in single port surgery, or you think it's the better option for your patient, Applied Medical has the best single port device in the market. So the gel that you see here, which you can put the trokers in, is a pseudo abdomen. This is not the size of the incision, but we created an abdomen over the incision that will allow you to put your trokers in and do the surgery without the need of any articulated instruments. You can do all your surgery with straight instruments. So as you can see here, it is a sleeve gastrectomy. And let me point to the picture here in the middle. Part of our device is the Alexis wound retractor, which can be as small as 1.5 centimeter from what you see here, up to 7 centimeter. So in your case, in case of a bariatric surgery, as you see, the incision is around 2.5 centimeter, which will allow you to remove the sleeve in case needed. And this is what the incision looks like at the end of the surgery. Please, just another disclaimer, please let me say, we are not advocating with or against the single port surgery. I know this is debatable in the surgical community, but in case you are using this method or interested in it, we have a very, very interesting technique for it. I've heard a lot of you talking about the bypass today and measuring the bowel and measuring where you're going to be the anastomosis. So we also in our graspers have the lattice mesh pad, which will give you traction on the tissue without leaving any footprint. So it's almost zero footprint. We have it also in our cardiovascular line. So this is how sensitive it is to the tissue. And as you see, there is the mark of 5, 10, and 15 centimeter that you can use while you are measuring the bowel. What I spoke very quickly about 3-4 lines that we have, but applied portfolio is very, very big. And if the time allows, I know it's already probably around 10:40 in Iraq. So if the time allows me, I would have spent hours talking about our portfolio. I just wanted to give you a little bit of taste of what we are carrying. But we do have a wide range for surgical specialties, retrieval bags, gel, other kinds of instruments, clip appliers, wound retractors, etc., etc. For more information, you can contact our distributor, مكتب الحلول المتكاملة, ISM in Iraq, or you can visit our website where all the products that I mentioned and a lot more are over there. And you can learn more on how you can evaluate and use our products. And hopefully we look very forward to benefit you in your practice and to benefit your patients from that. Please, if you have any questions, I would love to answer them.
Thank you, Dr. Sankari, for this presentation of applied products, wonderful products. And we hope to receive your products in the market and let our surgeons to try it. Now we go for the Covidien by Abdullah Ali. He will present the Smart Stapler or Signia system. Welcome.
Good evening, gentlemen. My name is Abdullah Ali. I'm Covidien MITG Senior Supervisor. I held this position since 2015 until now, and I am honored here today to be with you. So now I'm going to present you our new Mercedes, the first new smart stapler in the world, the Signia system. But before that, please let me tell you why we need the Signia stapler, why we need the smart stapler versus the manual stapler. So to do so, we need to go a little back to the history. This is our history in the stapling portfolio. Here we start with our journey in 1960 with the opening staplers and the circular stapler. Later on, in 1990, we introduced the first endoscopic stapler, and later on in 1995, we introduced the first endoscopic stapler with the articulation, and then in 2005, we introduced the thick tissue rayloid with the articulation. Later on, in 2010, we introduced our bigger hits, the tri-staple technology, which make the life easier and safer. And this is personally, which I very proud with my team, that we could perform over 17,000 bariatric surgery in Iraq. And to illustrate what the main benefits of this technology, the tri-staple technology, the tri-staple technology generates less stress on tissue during the compression and the clamping, and also allows a greater perfusion to the staple line and provide you outstanding performance in the variable tissue thickness. In this slide, you can see our legacy stapler, how much as applying of force on the staple cutting line edge, which increase the possibility of necrosis and ischemia. Besides this, you can see here with the tri-staple technology that in this slide that the blood supply and the nutrients, other nutrients can reach to the cutting edge, which help in the hemostasis and faster healing. Here, we can see that the best shape of the staple line is the B shape, as this shape, which give the compresses to the tissue, provide hemostasis while allowing the nutrition to be reached to the cutting edge, and which reduce the necrosis and the ischemia issue. In this diagram, you can see there is a relationship between the staple line formation, and the holding strength, which means if the staple shape is good, which means that the staple line holding strength is good. So here we're back to the Signia to see what the Signia could provide us with. The Signia Smart Stapler is a single-handed control, is a fully powered. You can open the jaw, close the jaw. You can do articulation, rotation, and firing with only one-handed. Second, the most consistent staple line through the adaptive firing technology. This technology, which use or measure the tissue thickness in the clamping jaw, and then set the firing speed to the stapler to give you the optimal firing staple formation. Third, it gives you a real-time feedback, which means that when you clamp a tissue over thick tissue, the device will measure it and will tell you that this tissue cannot be fired and you need to replace the staple or reclamp the tissue. بس حتى اوضح انه الفكره شلون تشتغل الادابتيف فايرنج تكنولوجي. بعد دراسات كلش واسعه سوتها الشركه، شافت انه اكو علاقه وطيده بين انه شكل الستيبلر شلون يتكون من وسطه من تكون السرعه مقابل التيشو ثيكنس. فكل ما كانت السرعه سريعه وكان التيشو ثيك راح تزيد احتماليه انه الستيبل فورميشن حيكون به غلط. فبعد دراسه كلش طويله استنتجوا انه طلعوا بالجوريثم حطوا بها قياسات، بها تيشو ثيكنس، بها سرعه مختلفه للجهاز، وخلوا الجهاز هو يقرا هاي الارقام، وعلى اساسها يحدد سرعه الجهاز وكميه السرعه اللي ممكن ينطلق بها وكميه القوه اللي ممكن يضيفها الجهاز حتى يحصل على احسن ستيبل لاين فورميشن. هاي هنا أنا يوضح السلايد اللي حكيته قبل شويه. So the adaptive firing technology will give you triple less malformed stapler against the manual staple, and will give you 50% stronger staple line over the manual stapler. This is the diagram show the Signia and its components, noting that the Signia, each single Signia stapler device could perform 300 surgery case. Before I end this session, I need to share this video. Thank you very much for your listening. Thank you, Dr. Nazar.
Thank you, Dr. Abdullah. And it's really a very Signia is a smart, reusable stapler. We are waiting for the discount prices. Now we go for the first presenter from Luigi Boni. He will speak about we will have a video presentation about the case discussion with NIF Technology.
Surgery at the Polyclinical Hospital in Milan. Today we're going to talk about fluorescence guided surgery, focusing our interest in fluorescence cholangiography. Fluorescence guided surgery is a fairly easy technology that is based and gives the ability of the surgeon to see the invisible. It's based on a very simple principle, the use of a fluorophore, a molecule that is invisible as standard light, but can become fluorescent in emitting energy by using a laser beam or a near infrared light. At the moment, the only clinically available fluorophore is ICG, indocyanine green. ICG can be diluted in standard water. Usually 25 milligrams of ICG are diluted in 10 ml of sterile water and can be injected either IV or local. We don't need much ICG to perform fluorescence guided surgery, usually 0.1, 0.3 milligram per kilo, according to the use. Once diluted ICG can be stored for up to 24 hours, so one vial can be used also for more than one patient. There are very little contraindication for ICG. The allergic reaction reported in the literature are very limited. Most of the ICG, they contain a little bit of iodine. If there is an allergy of iodine, it's better not to use, and probably also in pregnant women. To perform fluorescence guided surgery, you also need a dedicated system. The Synergy ID by ROUX endoscopy is a 4K system that allows you to get a fantastic 4K image in standard light. And you can also combine the 4K image with the fluorescence mode that allow the surgeon to take all the advantages of fluorescence guided surgery. We're going to focus now on fluorescence cholangiography. Why we're talking about fluorescence cholangiography? Because unfortunately, nowadays, still the incidence of common bile duct lesion is 0.3%. Every year in the United States only, more than 750,000 laparoscopic cholecystectomy are performed. That means that every year in the United States, 2,000 people, more than 2,000 people are suffering from a biliary tract lesion following laparoscopic cholecystectomy. Can we accept this number? Probably not, because it's like if we accepted every day at Heathrow. In standard time, we have 4 airplane accidents coming each day. So this percentage are still First of all, you need to prepare and to inject properly ICG. As I mentioned, ICG comes in vial of 25 milligrams, so it can be diluted in 10 ml of sterile water. An IV injection is performed usually at least 3 hours before surgery, even better 5 or 6 hours before surgery. Usually the amount of ICG is very limited, 0.2, 0.1, or 0.3 milligram per kilos, according to the timing of the injection, and is an IV injection just before surgery. Indocyanine green is a molecule that is not only fluorescent, but actually is excreted by the body through the bile. So very quickly in a healthy liver, ICG, once injected into the bloodstream, is linked to the protein and then is picked up by the hepatocytes. Once it's in the hepatocytes, is excreted by the liver through the bile. So you will be able to detect ICG everywhere where bile is present, meaning the gallbladder, the biliary duct, and of course, once the bile reaches the intestine, even into the intestine as well. As I mentioned, ICG can be stored for 24 hours, and 1 vial of ICG can usually be used for more than 1 patient. What does allow to do fluorescence-guided surgery for fluorescence cholangiography? Well, this is actually a standard view of a standard laparoscopic cholecystectomy. And this is what we are used to be able to see it. Well, using a fluorescence cholangiography technique, what we can do is actually moving from this kind of view, just clicking a simple button on the camera head and to move to this kind of view. And as you can see here, you obtain a 4K image with a superimposed visualization of the biliary tree. How you can do that? Because in the biliary tree, there are bile. The bile is combined with the ICG, and the ICG can get fluorescent. So you can detect the gallbladder, the cystic duct, and the common hepatic duct, as you can see in this picture. The fluorescence system from ROUX allows you also to have a different visualization mode. You have a standard white light, a superimposed fluorescence mode, you have a black and white mode, and you have a fully fluorescence mode. Well, as you can see in the fully fluorescence mode, you only pick up the fluorescence, but of course you have a dark field, so it's very difficult to use during the dissection. So it's better, to our experience, to use a superimposed image, also because the quality of the image is not really changed. As you can see here, this is a small video, a short video of a standard laparoscopic cholecystectomy. The benefit of the fluorescence system from ROUX, the Signia GID, is that there is a very powerful system and keep the 4K image all over your procedure. And that means that you can also use a 5mm scope, as in this case. And as you can see, the quality of the image of the 5mm scope is actually very impressive. You can work in the fluorescence mode all the time. And as you can see here, this is the kind of visualization that you have in real time. So the visualization of the gallbladder, the cystic duct, and the common hepatic duct. And as you can see, if you move to a 10mm scope, of course, you have a better visualization. The quality of the image is slightly better. The fluorescence system allows you to move to different modality, standard light, superimposed, black and white, and only fluorescence. You can also actually customize the intensity of the fluorescence visualization. Here you can see you have a higher intensity because you customize the intensity of the near infrared of the fluorescence mode, and you actually also can identify very nicely the contrast with structure. Of course, if you increase the power of the laser beam, you will have a little bit of background fluorescence in the liver, as you can see here. So sometimes this is very useful when you have very thick inflamed tissue or you have a very high BMI patient. Another benefit of the Signia GID system is actually you can also choose the type of color that you can have it. This can be extremely useful when you actually have a surgeon that have a problem with the identification of the green. They are partially colorblind. So the fluorescence can be blue or very light blue, as you can see here in this case. This, as I mentioned, was a standard laparoscopic cholecystectomy, very fairly easy cholecystectomy. Of course, the main benefit of the fluorescence cholangiography comes when you have inflamed or acute situation. This is actually an interesting video. It's a Mirizzi type 1 syndrome, where the common bile duct was compressed by a big stone that you saw here and the infundibulum of the gallbladder. Here, of course, the tissue are much more inflamed, so you will need to have a little bit of dissection of the triangle of Talon, and actually suddenly you will find this area of fluorescence over here. And this is actually where the bile is, and is very likely to be, the common bile duct. You can see also that the common bile duct is followed by the hepatic duct just posterior on that. This is the gallstone that you have here, and you see the common hepatic duct and the hepatic duct going towards the liver. As you can see, you can use the superimposed fluorescence mode just to perform your dissection and actually be sure not to accidentally damaging the biliary tract. As you can see here, in this case, the stone was closing the cystic duct, so the cystic duct is not fluorescent, the gallbladder is not fluorescent. There was this structure on the side, so you're not sure if that is the cystic artery. You can actually ask the anesthetist to inject 2 cc of indocyanine green IV, and you will perform an angiography, and you notice the presence of the hepatic artery and the cystic artery. So you can clip the cystic artery very nicely to be sure of the anatomy of the triangle of Calonne. What are the data of the literature? Well, there is this randomized control trial that has been published in Annals of Surgery in 2019. We were part of this study. It's a randomized control trial where we actually divide the group in standard light and fluorescent group for fluorescent cholangiography. The primary endpoint could not be the reduction of common bile duct lesions because we will have to have too many patients for each arm to perform this kind of analysis. So we use surrogate, and the surrogate were the capability to detect the anatomy, to define the anatomy of the triangle of Calonne. So basically what we obtained, well, the results were very interesting because the difference was statistically significant in favor of the fluorescent group in the identification of the anatomy of the triangle of Calonne. This difference was statistically significant before the dissection and does include also the identification of accessory duct rather than just the common bile duct, the hepatic duct on the cystic duct. This difference was maintained statistically significant in favor of the fluorescent group after the dissection of the triangle of Calonne. This difference was statistically significant in favor of the fluorescence group for high BMI patients, for acute cholecystitis, and this difference was actually statistically significant even if we are expert surgeons and novices, meaning that fluorescence cholangiography can be very helpful, not only for people that have very little experience, but also for experienced surgeons. In conclusion, we can say the fluorescence cholangiography is definitely a technique that can be extremely easy to reproduce. There is no learning curve. It's definitely cost-effective. It's safe. It doesn't actually have any danger for the patient. There is no X-ray involved, and actually can actually be useful in order to prevent the common bile duct lesion following cholecystectomy. Thank you very much.
Thank you for the presentation of the ICG from Luigi Boni. We appreciate the help of ICG in biliary surgery and the anastomosis margin viability. Now the final speak will be to Hassan Wahbi from Ingenious. He will speak about introducing the Ingenious Medical from Germany. Welcome, Dr. Hassan.
السلام عليكم مساء الخير جميعا. أول شيء thank you very much Dr. Nizar for the introduction. Special thanks for the chairman Dr. Muayad and Dr. Ramiz Al Mukhtar and all the panelists. I'm happy to be here with you. We met already with some of you like a few months ago in Beirut during the clinical workshop which we attended in Lebanon. And I'm gonna start directly now with an overview about Ingenious Medical company presentation. I think most of you are already aware about our product range. We met several times with most of you as a surgeons and all the stuff available down there. So I'm just gonna start with an overview clarifying the history of Ingenious Medical. We are a company based in Freiburg, southern part of Germany. Our business for the past 40 years was only under OEM manufacturing, original equipment manufacturing, which means that Ingenious Medical كانت تصنع البرودكتس وينباعوا بالأسواق مباشرة through other suppliers بس مش تحت Ingenious Medical. فكان بس Ingenious شغلها يكون كمصنع. As I mentioned, we have 3 different headquarters in Germany. Freiburg is the main headquarter. We have 2 manufacturing sites in Tuttlingen and 6 manufacturing sites in Dinselgen in Germany. All of them are in the southern part of Germany. So basically, our product range covers 5 different indications: laparoscopy, urology, gynecology, and recently we have added the complete portfolio for arthroscopy and ENT surgery. Most of our surgical instruments are classified as reusable instruments, disposable instruments, and reposable instruments or semi-reusable instruments. So we offer the complete product range of surgical instruments for laparoscopy, urology, gynecology surgery, in addition to the surgical staplers, which we're going to have a special window during this presentation. As you are most of you familiar with our products, you know we're offering the complete reusable product range for laparoscopic surgery, starting from reusable trocars, carbon fiber handle monopolar and bipolar instruments, all kinds of retractors, needle holders, laparoscopes, and all other laparoscopic instruments. At the same side, we are also offering the complete range of disposable laparoscopic instruments, like the staplers, for example, the linear stapler or the endostab stapler from Ingenious, suction irrigation tubes, endo bags, monopolar and bipolar disposable instruments, in addition to the trocars. Coming into the surgical stapler, we're offering the endoscopic linear staplers, our endostab, the very well-known stapler in Iraq, in addition to the linear stapler for open surgery, circular staplers, intraluminal circular staplers, and PPH staplers for hemorrhoid. One of the main focus of our product, which may be an interest for you as surgeons, is the use of our endostab, the endoscopic stapler, through our unique enhanced technique in special force of compression. As you know, we're offering our stapler in 3 different sizes depending on the type of surgery and depending on the type of patient, in addition to the weight and the size of the patient himself. And we're offering, until now, 3 different types of reloads, well known as the aqua, orange reload, and the brown reload. Each of those cartilage dependent on different staple heights in order to represent the cutting line upon the tissues. You can see the different stapler height available with the aqua, orange, and the brown reloads. One of the most beneficial diagram would be the clarification of the comparison between the thickness of tissue and stapling of the endostab compared to other competitors, which is also available in your market. You can see clearly through our brown reload, for example, we are the only company which offering a staple thickness of 5.2 mm. for extra thick tissues. One of the most important features which we're gonna discuss about the endostapler, that our technology depends on the force of compression on the reload itself and the handle, which means that regardless the speed of firing which is applied on the stapler itself, it does help in the manual compression of the tissues. So the surgeon doesn't need to put any extra efforts while firing. You do have a one push firing mechanism. You can do the firing in a fast way or in a slow way, regardless the thickness of the tissue, based on one reason, based on the stiffest compression force available for any stapler in the market. And other teams, or in other words, you can see during your practice that our compression force is over 5 or 6 times the compression force on tissues on any other competitor available in the market, without causing any external lesions on the tissue itself. So the osmosis mechanism can take place way faster on the tissue from one side. The mechanism of firing could be controlled manually from the surgeon. The surgeon doesn't need to be aware in case he's doing a fast firing mechanism or a slow firing mechanism, because the thickness of the tissue is not a problem at our end. With our compression force, automatically the clamps of the reload gonna release all extra tissues with the clipping factors. One of the most upcoming projects which we are dealing or working on right now, I think most of you are already heard about them, is our pink reload, which is the single height stapling force reload, could be used during the last fire for gastric sleeve surgery. Our pink reload will be released hopefully by Q2 of 2021 after getting the quality assurance certification for this product. One of the most patent products for Ingenious Medical is the 75 mm reload stapling technique. So we already have a patent for the 75 mm reloads. In other words, you as a surgeon, you're gonna have a cutting force of 7.5 centimeters. Or our current clinical research do prove that a gastric sleeve, for example, could be performed using 4 reloads. So you can purchase 4 reloads with the same price of 5 reloads, obtaining a one straight cutting line with extra cutting mechanism, in addition to maintaining a high compression force, which is more times 6 to 7 times than any compression force available with any competitor in the market, in case it was a manual force or a motorized force. Moreover, we are developing right now our handle. Hopefully by the beginning of next year, we're gonna have a completely new handle ergonomic design, helping you to control all the mechanism of grasping and firing within one hand action. As you know, most of you already use our staplers, our trocars at the market once you purchase the bariatric kit. So we do have the bladed, bladeless, and optical trocars, which could be used. The dimensions of trocars do vary from 3 mm till 15 mm, depending on the diameter of the instruments you are using. And latestly, we already launched our 150 mm or 15 centimeter length trocars for mainly bariatric patients. In all models of bariatric, in all models of optical trocars, bladeless trocars, and bladed trocars. So you can see the inner double sealing of our trocars. In other words, you can simply use our trocars or the 12 mm, for example, trocar without need any reducer in case you just need a 5 mm instrument. So we do have 3 different valves inside one trocar, 2 silicon valves and trapezoid valve inside one trocar, which means that you can assure that no gas leakage can take place or no extra reducer needs to be used or inserted inside the trocar itself. Moreover, for our complete portfolio, also most of you are aware about our compact system product range. So basically, Ingenious is not a company performing only or manufacturing surgical instruments or reusable or disposable ones. Well, actually, we are also one of the biggest suppliers in the market for the camera systems or endoscopic towers. For cameras, light source, monitors, insufflators, trolleys, and recording systems. So basically, we are the supplier for a very well-known brands available in your market right now in these days. We do manufacture the camera systems of Medtronic, Smith & Nephew, Fujifilm, Richard Wolf, Stemma, and the Stryker. We are talking about the Full HD and the 4K camera systems. Those are manufactured by Ingenious Medical. Moreover, we do have one of the leading edge in the market, which was launched last year. It's our 4K camera system. So basically, we are offering a 3-chip 4K camera system. It's not a single chip camera system like most of the current towers available in the market. It has an automatic algorithm. And one of the best features that it could be used typically with any camera from Ingenious Medical, like 4K cameras, Full HD cameras, 90 degrees cameras, for example, in urology application. So it's a very simple plug and play mechanism, knowing that our camera systems for sure are compatible with every single scope available in the market. So basically, if as a surgeon, you do have the surgical instruments and the telescopes from other suppliers, you can directly connect them to our camera system and the system will operate normally. You don't need to get any adapters and extra connections at your end. Least but not last, we're also in collaboration with Sony Medical Japan. We do have a complete integrated solution and archiving system for the operation theaters. We've done a lot of projects where the hospitals can connect all the operation theaters into one server, which could be accessed like online a server or through an offline system. The surgeon can have an access on all his surgeries, all patient data, and historical medical background for the patient himself. So this is an overview how can we connect every single display available in the operation theater into our service in collaboration with Sony Medical in order to have a compact archiving solution, which is also expanded in those terms into the automated control of our equipments, like the automated, like for example, the tablet control of our cameras and light sources. So you don't need to have a direct contact with the camera to activate any function inside it and the controller itself. One of the things which we are also developing, and I think it's going to be launched by next week, is our new website. Some of you tried to access the website in the couple of weeks, the last 2 weeks actually, and it was totally offline because of the renovation of our website, including all the features, especially for the surgeons themselves. You're going to have the feature to register in all the events worldwide offered by Ingenious Medical directly through accessing our website, putting down your data, and you could be sponsored from our site for any event which is offered on our website. You can have download access for videos and media center available on the website, in addition to our 24/7 online service. So in case as a surgeon you're facing any problem during any operation at any time, you can simply contact our team, upload the problem, upload a short video, and you can get a direct online assessment over the 24 hours, regardless of the day and regardless of the time. So hopefully our website will be launched by next week, end of next week, the new version of the website. And this is all what we can say about Ingenious. Like, as you know, I'm looking forward again to meet you all. Inshallah, we're gonna meet very soon again. We already discussed with our partner Plus Pharma in Iraq, and we'll collaborate a lot of visits, especially that we already have an MOU agreement with the Bariatric Society in Iraq. So would like to know that we are always ready for support. We are always available for any education and sponsorship possible. And it was really a pleasure to have you. Congratulations for this complete virtual event. It was great. Thank you all.
Thanks, Dr. Hassan Wahbi, for representative of the Ingenious, for his genius introduction of his products.
Thank
you very much. And now we are just over time, allowed time. We are great thanks for the panelists. We are great thanks for the speakers. And I shift the speech to the Mr. Chairman for the conclusion.
Thank you, Professor Nazar. So we reached to the conclusion of our webinar for the second Iraqi annual conference, Iraqi Society for Bariatric Surgery. And again, for the second year, the dream become a truth. الحلم صار حقيقة by the efforts of all. Special thanks for all participants, moderators, speakers. Thank you very much, Professor Nazar, for your great role in moderating our webinar. Thank you very much, Dr. Ramiz, for your participation and moderation of the webinar. Thank you for all speakers. A special thanks to Dr. Mohammed Al Hadad and Dr. Hayssam Alfawal for their participation in our webinar and for their continuous support for us. And it was a delighted 3 hours that will not go from our memory. And a special thanks for the EFSO committee. A special thanks for the Dr. Abdul Samia, the responsible of the IT company. And a special thanks to Al-Jundi Al-Majhool, and non-soldier Dr. Muhammad. He get a great role in moderating our webinar regarding the IT.
Thank you, sir.
Thank you very much, Dr. Muhammad.
Thank you, sir.
We hope on the next year that we will meet in a real conference in our country, inshallah, after this crisis finished. And we're hoping our God will protect you and your families. And sorry for any mistake or delay in the internet that occurred during the webinar. You know the circumstances of the internet and the IT problems. Thank you for all. We hope to meet on the next year. Thank you very much. Good night.
Good night. Congratulations, everybody.
Thank you very much.